simply breathing is a daily challenge. Observed annually on the first Tuesday of May, World Asthma Day was first held in 1998. Its purpose is to highlight that while asthma is chronic, it's still manageable. Many people suffer in silence, limiting their lives due to preventable symptoms. Today, we emphasize that with proper education and access to medication, no one should have held their life back by asthma. This year, Gina particularly raises a critical, urgent need, which is access to anti-inflammatory inhaler therapy for everyone with asthma. Light brings warmth, hope, and positivity. To officially inaugurate today's event, I would like to invite our President of Sri Lankan College of Pulmonologists, as well as our speakers, to light the traditional oil lamp. First of all, I invite Dr. Sumana Handagala, our President of Sri Lankan College of Pulmonologists, and Senior Consultant Chest Physician Dr. Amita Fernando, Dr. Dilesha Vadasinghe, Consultant Chest Physician, Professor Christine Jenkins, Dr. Vipula Bataduarachi, Dr. Afla Sadikin, Consultant Chest Physician, Dr. Chandana Dahanayaka, Consultant Chest Physician, thank you. First of all, to set the context to the event, I would like to invite Dr. Sumana Handagala, the President of Sri Lankan College of Pulmonologists, Consultant Thoracic Surgeon, National Hospital for Respiratory Diseases, Valisara, to deliver the opening remarks.
Thank you. Good morning to everybody, all the physical as well as online participants. You all know the reason for our gathering today is to have an academic event with regard to World Asthma Day, which falls tomorrow. So this is the theme for this year by Gina, the access to anti-inflammatory inhalers for everyone with asthma, still an urgent need. It highlights the critical need for equitable access to essential long-term control medications to prevent asthma-related deaths. And he mentioned about the burden of asthma is about 260 million globally, and it causes about 450,000 deaths per year. And 96% of this would happen in low and lower middle income countries, unfortunately. So a cross-sectional study done a few years ago in 7 provinces of Sri Lanka showed that prevalence of asthma in adults is higher than other South Asian countries, and it's higher in all the age groups. And significant proportion of individuals did not report having asthma or being on medication. So I just found this in internet, the evolution of asthma care from ancient era to 2020s, and it has been reported even the time of Hippocrates and evolved like this. I'm not going to go into detail. This is how the asthma care has evolved over the time. And now it has become inhaled corticosteroids and precision care catered individually to patients. So I would like to welcome our asthma assembly of the college, presided by Dr. Samamalli, and there are other members as well. Thank you very much for organizing this academic tours to commemorate Asthma Day. And I would like to welcome all speakers, the almost eminent local speakers, as well as incidentally, we found Professor Jenkins, who works in Australia, and we are privileged to have her here. But she has been on her holiday actually this time. But we need to thank the clinical trials unit of the Kalani University, Professor Asita, who has organized and made her contact so that we are lucky to have her here. She's an eminent figure in the field of pulmonology in Australia as well as worldwide. Thank you very much for attending and supporting us. And again, I thank you for physical and online participants and Sri Lanka College of Pulmonology office staff, sponsors, our media workers, as well as the senior registrar who came. Thank you very much. We'll crack on to the program. You all are welcome.
Thank you, sir. The first item on our agenda is the session on the reality of asthma care in Sri Lanka, gaps, challenges, and opportunities. This session will be led by Dr. Vipula Bataduarachi, Senior Lecturer and Specialist in Respiratory Medicine, Department of Pharmacology, Faculty of Medicine, University of Colombo, as he discusses the current asthma care challenges in Sri Lanka and the way forward.
Thank you, Nishant. Good morning. First, I want to thank the college for giving this opportunity for me to talk on this topic. So, today I'll be talking about the reality of asthma care in Sri Lanka, gaps, challenges, and opportunities, openly and very directly about our situation and what we should do. So, outline of this talk, where we stand in asthma care in Sri Lanka at present. Then gaps and challenges in the asthma in Sri Lankan context. Reasons behind shortcomings in our asthma care. Realistic approach to overcome challenges in Sri Lanka. Future goals to improve asthma care in Sri Lanka. Very carefully selected words, and I'm focusing on our context. Few words about positive things. So I'll start with the positive things. Over the years, we have seen that the evolution of asthma medications from oral medications to inhalers. In 19s, I can remember we were using salbutamol tablets, prednisolone, but now we have availability of inhaler devices. Then at some point, asthma was not considered as a NCD. NCD was completely metabolic syndrome, but now it is considered as a non-communicable disease. And also now we have well-trained respiratory specialists in peripheral stations. And also we are trying to start specialist asthma clinics. Then patient education has improved to some extent. Then training and CME programs like this are regularly happening. So we have certain positive things in asthma care in our country. Next, I will go move on to the gaps in and challenges in our asthma care. Generally, there is widespread misconception among patients. Still, that problem is there. Still, patients think inhalers are addictive, and also they think even medical professionals think every wheeze is asthma. Then poor health-seeking behavior among our patients, and also language barriers. So there are multiple problems we can see still among our patient population. Then stigma on patients. Actually, stigma causes more harm than the disease itself for patients. Then financial burden at every level, from patients to the government. There are people who can't afford for medicines in our country. Then the differences between government and private sector. We have to acknowledge that now the upper middle class is growing, so spectrum of facilities should be available, but the principle is minimum facilities should be available at the government hospitals. Then the unavailability of diagnostic tools, medicines, and devices. Actually, I noticed that tiotropium was not available few months back, and I actually questioned that why it is happening. I actually reached some of the high-profile figures to check, but I didn't get a proper answer. And day before, I noticed that even salmeterol fluticasone combination was not available in certain hospitals. So we are sometimes talking about sophisticated plans while we don't have even basic facilities. So that's an important thing to consider. Then equipment-wise, we don't have even manpower and equipment. We don't have certain equipment like spirometers, right? They are very expensive and we don't have funds. Then manpower-wise, sometimes we don't have trained staff. In other countries, we have asthma nurses, asthma physiotherapists, asthma physiologists, but we don't have that kind of trained manpower. The limited fund, as I mentioned already, we have funds actually, but funds are not prioritized. So we have to understand that. And also sometimes I feel we don't use funds properly. We don't get the maximum out of funds which are available. There's something about the data. Now, if you look at this chart, you can see these figures. Actually, I'm concerned about the reliability of this data. We don't have reliable data in our country. We go by small studies or we go by unreliable data. The problem is sometimes we don't diagnose and document properly. I have seen junior doctors sometimes write diagnose as asthma. There is nothing like that, either diagnose or not, right? So that type of scenario can contribute to unreliability of data. So that's an important problem. Data is important to make decisions, even to the government. So we can't blame the government without producing reliable data. Then unavailability of prevalence data. So we can't contribute, we can't show our data we can't combine with, integrate with regional databases, global databases. One problem is we don't have electronic patient management systems. I know that people have tried to establish that, but we have problems coming behind them, like poor maintenance, lack of training. So we are not able to sustain, even though we start sometimes. Then overdiagnosis, underdiagnosis, misdiagnosis is common in asthma. Asthma is a very straightforward condition. Still, we make mistakes. Like preschool, we should not diagnose kids with asthma unless we diagnose. Otherwise, stigma will destroy them. Then sometimes these early heart failure patients at the other end, little bit of interstitial edema, they present with wheeze and they are diagnosed as asthma. Then recurrent viral infection, sometimes diagnosed as asthma. So it's a very common scenario. So it's sometimes inaccurately diagnosed. Then breathing pattern disorders. Another common problem is diagnosed. The problem is we don't have a proper screening program in place in our country for kids and for adults. And no systematic approach, because asthma is a very straightforward condition and we need a systematic approach. We don't have in our healthcare culture. So it's a cultural difference. Unless we change that culture, it's very difficult to establish that. Then comorbidities are not assessed and treated. Before my foreign training, I also thought asthma is just like giving inhalers and something like that. But after seeing their management, I understood that it's a kind of a comprehensive assessment and management. Then no validated tools to our local language. Now there are a lot of tools to diagnose, assess severity, assess comorbidities, but the problem is these are not validated. We don't have the culture of using them. We always make that we have escape routes to not to use them. Then spirometry and bronchodilator responsiveness. We don't have spirometers available. As I mentioned earlier, very expensive, we don't have a category of staff as respiratory physiologists. Oh, that's a big gap in our healthcare system. Then the stepwise management is not performed by our healthcare practitioners. Of course, its number one factor is negligence. Then poor documentation, and we are not using appropriate tools. The common answer is we have a lot of patients. So actually that's a problem, but we should be able to manage that problems in a scientific way, like decentralizing asthma care to peripheral unit and triaging severe asthma patients. Then we will get more time. Then this is one of the studies we presented in European Respiratory Congress. I'm going to show you some interesting data. Now in this, you can see eosinophilic asthma is quite significant in this cohort. I also never thought that eosinophilic asthma is not common in our country. I even argued with my foreign supervisor that it's not common in our country. But after coming here and doing this small study, I understood that it's not uncommon, right? It's common, it's there. Then we found out another important problem. Majority were females. That doesn't mean actually asthma patients are majority are female. This means there is poor representation of the sample because patients are probably male patients are not presenting to the asthma clinics. Then the mean age was 51. The most important thing, median age at symptom onset was 37 years, and the median age at diagnosis was 45 years. So there's a significant diagnostic delay. There can be recall bias in this study. This is a small cohort, but it's an important thing to understand. Then we divide the sample into two, high eosinophilic and low eosinophilic groups. So we high eosinophilic group, the age at diagnosis is earlier than the low eosinophilic group. That means high eosinophilic group has more severe symptoms. And also the spread of the time taken for diagnosis is more in high eosinophilic group. Then something about poor other challenges in the management, poor compliance and improper inhaler technique. That is key in asthma management. So that is common. Actually, it's common to everywhere. Problem is we don't check it regularly. Nor train allied healthcare professionals. In other countries, asthma nurses do it. Even they handle MAB clinics. Then management of mismanagement, like excess use of steroids due to lack of spectrum of essential medicines. Actually, we should have a spectrum of doses and types of inhalers. So that is not there. When one is available, other one goes missing. So that's a problem in our country. Then stepwise management, use of high dose of inhaled corticosteroids, low use of tools, not giving self-management plans. So this is a kind of a network of problems due to same reason, having no structured system. Then we are not focusing on certain rare traits like dysfunctional breathing, vocal cord dysfunction. They're actually quite rare, but important to diagnose. Then unavailability of medicines. We don't have advanced treatment in the government sector. We can't blame the government also. We have to show some data to the government to make the decision. So we have to show them that this much of we are having this much of patients and we need this medicines in this style. Otherwise, we will never get it. Then this is another data showing from another study. You can see the commonly used medicine in our country are like this salmeterol, fluticasone combination and salbutamol. So we are not following even though we are discussing about global various ATS, BTS, ERS, GINA guidelines, we are not able to follow them because drugs are not available. So lack of proper system for drug estimation is a problem. We go by rough estimates. And also timely procurement is not there in our system. So we are facing a great barrier. We have to discuss these things openly, directly, and find solutions. Then gaps and challenges in documentation, no customized guidelines. Why I say customized? Then due to same problem, because we don't have the required tools and facilities. So we have to change the guidelines according to our setting, the resources. Lack of standard documentation and follow-up protocols. Lack of electronic patient management systems, as I mentioned before. Lack of data locally to relevant local relevant phenotypes like new antigen types, maybe biomass fuel related, maybe fungus sensitivity. Then special groups are not addressed properly, like kids and occupational asthma. Then limited access to asthma educational material. So you can see a whole lot of problems. So I am listing lot of negative things. So the reason behind this, IT infrastructure is still very poor in our country. There is a gap between communication with medical sector and the IT teams. Very difficult to get together and go for a common goal. I don't know the reason, but it's quite difficult. Then the maintenance and lack of trained staff. Then the next important problem is commitment from us. We always find escape routes. Now I will show you some positive things. Now this is a database we have tried to develop. Actually this failed 4 times, and at the end we were able to build up this database. Then about the gaps and challenges in the research. This is an important aspect lacking in our country. Air pollution is not assistant control. Now we are talking about air pollution a lot. From the neighboring countries, we are getting this clouds, and also luckily due to being an island, it goes away, but it's a problem, right? And also in urban areas and also up country. Then biomass fuel exposure is underestimated. Then work-related asthma is also often neglected. So these need very focused and carefully designed research. Allergens specific to local settings are not well understood. Sometimes we use these foreign-made tool kits, immune kits, but that may not show our local allergens. Then limited research in local population. Then also low-cost adjuvant treatment. I'll talk to you a few words about that also. Then limited collaboration within country and also internationally. Within country and also internationally. So that's again a problem in our healthcare culture. In other countries, system controls us, but here we try to control the system. Okay. So insufficient research skills and insufficient funds. So those are the key problems. So we have to train medical teams from their early days of training. Otherwise, it's very difficult to change that behavior traits. And this some of the data I'm showing one of the publication on microplastic. It's an important allergen that we have not considered so far. Then this is something about using local. We have, being a tropical country, we have a huge pool of chemical, plant chemicals. I'm not saying we are going to we should replace well-established treatment with these things, but we can try and explore our plant chemicals and see whether we can use this for mild to moderate cases as an adjuvant treatment. Then this is something we published this time. We sent a report to Global Asthma Network. It will be actually published today. So we mentioned about this air pollution, and you can see that photograph. Then I want to talk a few words about this project. This is an important pilot project we are conducting at present in collaboration with the College of Pulmonologists, Ministry of Health and the WHO. The main goal is to check the feasibility of a screening program for obstructive airway disease. So it's a very structured pilot project, and we have a customized pathway. We have developed it using various. We are using various tools, and we have developed a customized diagnostic questionnaire, and also we have developed app for patient management, a simple app. So this is an important project which will say whether what are the deficiencies and how we can improve. Then this is the customized guideline, acute management guideline, and one-page simple guideline for management. Why I'm saying using this word customized and simple, otherwise people will not look at them and not use it. So we have to use a very simple format and customize guidelines. Then these are some of the education material the team has developed. Actually, it's a very nice teamwork, nice collaborative work. Very happy to see that type of work. The problem with this education is our healthcare health education seeking behavior also not present in our community. So it's very difficult to give a message to them. Now we have tried various methods like YouTube, but for the likes we get for a gossip video like 5 million, and for educational video like 500. So that's a reality. Then future goals. I'm not going to go one by one again. I have already discussed some of the solutions to these gaps. One important thing I want to highlight here for the update of school medical, paramedical, teacher training curricula. So that's an important thing because that is where we can change the culture, healthcare culture. Otherwise, we have been discussing everything and discussing for years and years, but we don't get a result. Now going one step forward, I'm just showing you some. Now actually we are following other countries. So always we are following what is happening in UK, Australia, other countries. Actually we should think step forward and we should introduce our innovative things to our system. We should lead we should be the leaders to the other countries, not only just not just the followers. Now, like things like smart inhalers and biofeedback. I know it's very expensive, but that type of care can bridge some of the problems in the resource-limited settings. And also it will individualize precision medicine, precision care. Then virtual self-help group. Now everybody has a smartphone in their hands. So I have seen in the UK that they are using this virtual self-help groups. Then community-based care. So we can decentralize care to the community and also the peripheral unit. That will reduce the burden for specialist units. That will give us the opportunity to manage other patients properly. Then AI integrated databases that will give quick predictions on the patterns, high-risk groups, and also for health education. They will give a customized answer to a targeted question. So it's an important thing. Then precision medicine, like treating small airway disease with small molecules, and special care for kids just before exams, very finer things we can introduce. I'm showing one more article, right? This is a meta-analysis on digital and smart inhalers and digital technology in asthma care. You can see it's almost positive, but it's not widely popular. So what is the reason for that? We actually found out a lot of reasons. Even in the developed countries, it's not very popular, but it's a very useful way of managing patients, because the compliance problem can be addressed very nicely, and also health education also. We can assess compliance very objectively with these devices. Right. So just to summarize, I have discussed the gaps, challenges and opportunities very openly and directly. The message I want to give you, the systematic approach, integrating new technology to overcome barriers in a resource limited setting. Right? That's the message I want to give you. And thank you, and it's up to you to decide where I stand. I have given you the facts.
Thank you for enlightening us on the topic, sir. Now it's time for the token of appreciation. I would like to invite Dr. Sumana Handagala, the President of Sri Lankan College of Pulmonologists, to deliver the token of appreciation to our speaker, Dr. Bipula Bataduarachi. Thank you, sir. We now move to session 2, Asthma in 2026. From short-acting bronchial agonist era to anti-inflammatory reliever therapy. I call upon Dr. Niranjan Disanayaka, consultant respiratory physician at Teaching Hospital Kalutara, to take us through the advancement in asthma treatment.
Good morning, ladies and gentlemen. On the outset, I would like to congratulate and wish the very best to our new president, Dr. Sumana Handagala. And I think it's his first official college activity he's presiding today. And thank you, Saman Mali, for giving me the opportunity to give this talk as well. So I thought of starting this talk with this 2025 GINA introduction to asthma. And I would like to highlight 3 important things. Other than the comorbidities associated with asthma, which changes lives of people and the quality of life of people, unfortunately, asthma causes 1,000 deaths per day. And unfortunately, most of them occur in low and middle income countries such as ours. And the intriguing fact is that asthma is a preventable disease, is a controllable disease, and in spite of that, we are losing 1,000 people a day throughout the world, and at the same time, millions are suffering on a day-to-day basis. When we look at the Sri Lankan picture, which is a low middle income country, we have a very high asthma mortality rate. And in 2020, we were ranked 10th in the mortality of asthma deaths. And some of these deaths might be, yes, probably due to misdiagnosis, conditions like COPD or bronchiectasis masquerading as asthma and classified as deaths due to asthma. But we know as clinicians on our day-to-day practice, these deaths happen, like in this picture, a 14-year-old boy coming with a cardiopulmonary arrest to a teaching hospital who succumbed to asthma. So these are the realities, and I'm certain that Vipula elaborated some of the causes that might underlie these poor outcomes in the world as in Sri Lanka. Now, I think this year, GINA has identified an important area of asthma control. Now, access to anti-inflammatory inhalers for everyone with asthma is still an urgent need, was the motto this year. Probably the access is limited in a resource-poor setting like ours or the low-middle income countries, and hence the increased mortality. But is it the only cause that is causing this suffering to these patients? aren't we, as the medical profession, has some responsibility towards this? Are we denying anti-inflammatory treatment even when it is available to our patients? Especially in our guidelines per se, did we deny many patients who really needed anti-inflammatory treatment, and we just gave them an inhaler to relieve the symptoms, causing the increasing amount of deaths as well as suffering as the outcome? So it is up to us to decide. Let me take you back to centuries. People knew that basically the thing with asthma was airway constriction, and they used various connotations like, inhaled cannabis, inhaled datura, which has antimuscarinic agents. Some of them drank herbal teas which contains ephedrine, which has a beta agonist activity. So they knew that there's something wrong with the airway, and dilatation of the airway was the way forwards. And this beautiful pendulum by Anne Woolcock, who is actually one of the founder members of GINA, explained it beautifully how the shift of change of treatment went through. In the 1960s, asthma was considered as basically an abnormality of the airway, and hence regular beta agonists were prescribed. But later, in the 1970s, we understood that eosinophilic inflammation is one of the most important aspects of asthma, hence identifying at first that asthma and recognizing asthma as an inflammatory disease, as well as most of them responding to inhaled corticosteroids. Hence, in the 1990s, we actually shifted away from the bronchodilators, and there was a high percentage of people on high dose of corticosteroids. And you can see that at that time we identified that not only eosinophils, neutrophils and other cells are also causing the inflammation, and some of them didn't respond as it should be. And in the 2000s, again the pendulum shifted towards inflammation and airway smooth muscle abnormality coming together, hence the treatment plan of inhaled corticosteroids going into a low and medium inhaled corticosteroids together with a long-acting bronchodilator, which actually facilitate the action of the steroid activity as well. So basically, asthma was it was identified as an inflammatory disease needing corticosteroids or other anti-inflammatory treatment. And this is GINA at 2002. And obviously, mild persistent asthma, moderate persistent asthma, and severe persistent asthma, the place of corticosteroids with or without a LABA was highlighted. But what we identified as intermittent asthma was said as daily controller medications are not necessary. This is as far as early as 2002. That was a GINA guidelines. So what do we mean by step 1 asthma or intermittent asthma? Symptoms less than 1 week, brief exacerbations, nocturnal symptoms not more than twice a month, and the lung functions begin normal, and there is reduced variability of lung function. So are we happy at this month? Asthma being an inflammatory disease, which is a paroxysmal inflammatory disease, these symptoms, however infrequent when they come, are due to the underlying inflammation that is underlying in the lung. We have not given them the control medication that was available at that time. And the step 2, though most of these patients were prescribed inhaled corticosteroids, they have a higher frequency of symptoms. So even though the symptom burden was there, albeit within brackets mild, these patients were deprived of the treatment that is necessary to control the inflammation that was there in the lung. only in 2018, this is the 2018 DIN-GINA guideline, that we saw that in step 1, there was a recommendation to consider low-dose inhaled corticosteroids for this inflammatory disease. And again, it is only consider low-dose inhaler, but the main push was towards as needed short-acting beta agonist. So mild asthma is 1 or 2, 3, step 1 or 2 controlled. So what do we mean by controlled? There are less than 2 weeks of symptoms, no night awakening, reliever less than 2 times a week, and there is no activity limitation. But there are symptoms in these patients in the background, signifying that there in this, even the what we call so-called mild disease, there is a significant inflammation that is going on. Fortunately, in 2025, we were able to identify this and then change our diet management strategy to AIR. AIR is as anti-inflammatory and reliever therapy, where now steps 1 and 2 have come together, and these patients are prescribed corticosteroids in the form of budesonide or sometimes beclomethasone dipropionate together with formoterol. Formoterol is a rapid-acting, long-acting beta agonist which has a rapid onset of action. So it has took almost 23 years to get this into this system. But fortunately, now it is the standard of care, which is recommended as track 1 in the GINA guidelines. Now, even in track 2, whenever a patient is taken an inhaled corticosteroid, whenever the patient is taking a short-acting beta agonist, it is recommended that inhaled corticosteroid is taken at step 1. So whenever we give a beta agonist, a short-acting beta agonist, now an inhaled corticosteroid is recommended and it's given to to get the inflammation down. So we have come a long way from no recommended inhaled corticosteroids as recent as 2002 to a combination of inhaled corticosteroids plus a rapid-acting, long-acting beta agonist for the treatment. So most of the things, probably the inflammation that is going on will be addressed. And it has actually been a journey. From a short-acting beta agonist to an anti-inflammatory reliever therapy had been a journey. It probably had many people who advocated this type of management in the world, and fortunately for the patients, it has prevailed. So let us look at the underlying story and beyond. Is there a concept called mild asthma? Even though the patient might appear mild, having mild symptoms with minimum disturbance to the day-to-day activities. Now, this is according to the BTS step of the risk of exacerbations. Even patients with we called mild asthma have a significant 12 to 36% of them have exacerbations. And when they have exacerbations, we know that the lung functions decline. The increased amount of oral corticosteroids has to be prescribed, and the risk of death increases. And the decline of lung function also increases. So even though we say mild asthma, most of them are, at least 1/3 of them are prone for exacerbation. So mild doesn't mean mild. And when you look at the serious other adverse effect, in patients who are having acute asthma, around 30 to 37% of them were actually classified as mild asthma within the last 3 months. Out of 1 in 6 of the patient who had near fatal asthma, unfortunately, are the ones who had been classified as what we call mild asthma during the last 3 months. And unfortunately, out of 1 in 4 who dies with asthma are the patients who have been classified as having mild asthma during the last 3 months. So we can understand that mild asthma is a misnomer. So probably now in the GINA 2025 guidelines also, we are trying to get out of the word mild asthma because of the consequences that it has to the patient, and the impression that the patient has is, I have mild asthma, so why do I need treatment? And probably the impression that the doctor has, saying that why do we need to treat mild asthma? But the consequences are great. And the other important aspect is that when you come into the numbers, about 70% of the total population of asthmatics are what we call mild asthma. So these patients have a high degree of poor outcome. A significant proportion of them has poor outcomes. And at the same time, when you look at the numbers, it will be markedly elevated as well. So in a day-to-day basis, sometimes some of the patients, maybe 50 to 60% who are present to us with acute exacerbation probably would have had mild asthma, simply due to the fact that mild asthma is the commonest form. And majority of them are newly diagnosed. So if we don't manage these patients properly, the newly diagnosed asthmatics, the probability of them deteriorating and having irreversible lung damage is very high. So why not SABA alone? Why did we change from the SABA alone strategy? Because we know that salbutamol doesn't have actually an anti-inflammatory activity. And when we use salbutamol as a reliever, symptoms will be improved, but the inflammation will go on. And hence the patient will have continuous symptoms, and the frequency of salbutamol inhaler need will gradually increase in number. And that is why our Attammas has told that inhaler ekata purudu වෙනවා. That means they get used to the inhaler, because without the inhaler they can't live. So that is why there is this myth in the society has some scientific background as well. That is why they are reluctant to start inhalers, because of the SABA inhaler have solidified their concept that salbutamol, you get used to the inhaler and you can't do without the inhaler. And even when you take the inhaler, the next time you will not get the improvement that you had. So because this is going on and on, because of the beta receptor downregulation, reduced bronchoprotection, airway increased hyperresponsiveness and allergic responses, so people will gradually lose faith. And the second important reason is that even though we have given as required salbutamol for GINA 1, 52% are still uncontrolled. So salbutamol is not an inflammatory drug, hence it increases the risk of future exacerbations, and at the same time, when you look at the quality of life, patients have a poor quality of life. And according to the studies, if you use more than 3 canisters, if you have increased salbutamol use, the exacerbation rates almost double. And then if you have more than 3 canisters per year, mortality rates almost triples than in a patient who is not taking. So salbutamol is probably not the answer. So there are some patient factors associated with that. There's a scientific facts as well as the patient factor. This is actually one of our patients. When we asked to show the inhalers, he showed these 2 blue inhalers. So some people think that this is the inhaler that cures my disease because it helps them relieve the symptoms. They don't understand the importance of the brown inhaler. So the blue inhaler is the one that patient believes in. And it has been proven benefit, in various studies, in patients with even mild persistent asthma who have been prescribed the inhaled corticosteroids, 75% of the patients has only been using the short-acting beta agonist, and only 30% were using the controller as prescribed. So what do we mean by air? So to relieve that or to come out of this, the best thing would be to combine the controller as well as the reliever. So budesonide is the controller and formoterol is the reliever. Why do we use formoterol, not other types of long-acting beta agonist? Because it has almost a similar onset of action to salbutamol. So whenever the patient takes formoterol, they will feel that they will be relieved of the symptoms, as well as unknowingly they will be taking a dose of the anti-inflammatory treatment, which will actually take care of the inflammation as well. And as we know, unlike salbutamol, formoterol keeps in our body for about 12 hours of action per day. So what were the scientific evidence underlying this? Sigma 1, Sigma 2, novel start and practical are the studies which has looked at this. So I would like to highlight the Sigma 1 trial, which is actually the groundbreaking trial in this one. There, basically the patient took, in the first term, we had a placebo inhaler taken twice daily, which didn't have any drugs, but this patient took terbutaline as needed, as suggested by the management of mild intermittent asthma. And in the other group, they have a placebo twice daily, and on top of that, to relieve the symptoms, they took a budesonide formoterol combination inhaler. And the third one would be they took a budesonide inhaler twice per day, and then as needed terbutaline. And it was clearly electronically monitored. And what we saw in this study was that the blue is basically the terbutaline only inhaler taking people who had a very high severe exacerbation rate as well as moderate to severe exacerbation rate. And in this group of people who took the budesonide formoterol as needed and budesonide maintenance dose, the exacerbation rate were almost equal. Hence, scientifically proving the theoretic benefit of taking a reliever as well as a controller together. And this is a summary of the studies that I have shown. In Sigma 1, it has shown a 64% reduction of exacerbation compared to the as-needed salbutamol. In Sigma 2, it was proven that it is non-inferior to budesonide maintenance dose. And in the novel start, again, it has shown that there was a 60% reduction compared to the salbutamol or terbutaline as required inhaler in step 1 and 2, and in practical 31% reduction. So it has proven beyond doubt that this system works. And the evidence in the GINA 2025 is there. Compared to SABA alone, this AR therapy has reduced exacerbation rate by 65%, reduced hospitalizations by 65%, and improvements in the forced expiratory volume was noted compared to the SABA alone group. And even compared with the ICS and as needed short-acting bronchodilator group, the risk of visits to the emergency department was reduced by 37%. And both T2 low and T2 high people were actually responding to the treatment. And how would you take air? Basically, the low-dose ICS formoterol, which has 200 budesonide and 6 micrograms of formoterol, as needed in step 1. And then in the step 2, we can use the low-dose ICS formoterol, 1 actuation BD or 2 actuations daily, and use it as required as well. What about the price? Do we actually in Sri Lanka, in a low and middle income country, do we have a price comparison? Actually, we did the price comparison and we were able to prove that air therapy in the mild intermittent group is actually cheaper than using beclomethasone and salbutamol together for type 1 and 2 groups. So I think the year before, we have invited the NCD director here, and we were able to present these findings, and now there are actually important steps in making formoterol an essential drug in the primary care setting. So this is a beautiful story. So have we solved the mystery, or have we been able to reduce this? And unfortunately, asthma is a heterogeneous disease. We know that in severe asthma, there are various underlying biological pathways which causes severe asthma. And mild asthma cannot be different. So this air therapy fits all. So there are some pointers that we might have to be cautious when we implement air therapy, especially in the mild intermittent group. One comes in the Sigma trial per se, where we found that compared to the budesonide maintenance dose, BD dose, the smart therapy had poor asthma control outcomes. So patients were more symptomatic in this group. And the second important aspect is the lung volume reduction. So when we compared with obviously compared to the salbutamol terbutaline only group, there was a significant reduction in the lung volume. But when we compare the air therapy with the twice daily budesonide group, when you compare those, the air therapy group has low lung volumes compared to the other groups. So is there a signal here? It is a very important fact that we have to think about. And in Sigma 2, this was further proven, even though it didn't come into the clinically important difference, still the asthma control was poorer in patients who are taking the air therapy compared to the budesonide maintenance dose, and the post-bronchodilator FEV1 was poorer in patients who are in air therapy. So that signifies probably that we have to be a little bit skeptical in implementing this. Because inhaled corticosteroids, asthma being an inflammatory disease, inhaled corticosteroids have proven again and again that it protects lung volumes and it protects the remodeling of the lung. And probably we might have to think about it, because asthma is a chronic disease. It's a chronic inflammatory disease, and at the downside, the lung will remodel, and there will be irreversible changes if we don't treat the inflammation appropriately at the onset of symptoms. Hence, even in the mild group, there might be certain subgroups of people who might need long-term budesonide therapy. So those trials should probably be going on in the world, and hopefully it will come in the future as well. So one way of looking at it is that maybe the ways that we can look at is that, especially in this Oracle trial, which was a brilliant trial, which has looked at certain factors that increases the risk of exacerbation, fractured in exhalation of nitrous oxide and the blood eosinophil count has been identified as good markers for future exacerbations. Maybe we can find certain biomarkers in the mild intermittent group as well, rather than prescribing them blanket anti-inflammatory and reliever therapy. We might be able to, like the severe asthma group, arrange our treatment according to the patient's biological signal. Hence, ladies and gentlemen, I'm at the end of my talk. So, yes, anti-inflammatory inhalers for everyone asthma is an urgent need. And at the same time, again, like we have deprived patients who actually needed inflammatory treatment to maybe for the past 50 years until maybe about 5 or 6 years before, I think even in the mild intermittent group, we should be very cautious in implementing strategies, and we have to look in again and again so that we will prevent at least significant amount of exacerbation in this common group of people in the community. Thank you very much.
Huge thanks for such an informative speech, sir. Now it's time for the token of appreciation. I would like to call upon Dr. Amita Fernando, Senior Consultant Physician, National Hospital of Sri Lanka, to deliver the to token of appreciation to our speaker, Dr. Niranjan Disanayaka. Thank you, sir. Next up, we have session 3, Developing National Action Plans and Blueprints for Asthma and COPD by Professor Christine Jenkins. Professor Christine Jenkins was invited by the Clinical Trials Unit, Faculty of Medicine, University of Kelaniya. Professor Christine Jenkins is a program head, respiratory medicine at the George Institute of Global Health, professor of respiratory medicine at the University of New South Wales, Sydney, and clinical professor in the Concord Clinical School, University of Sydney. She has been the principal investigator and has led many investigator-initiated and competitively funded clinical trials in airway diseases. She has had major role in advocacy and leadership in lung health in Australia, most recently chairing Lung Foundation Australia, where she continues as a director, previously chairing National Asthma Campaign and federal government's National Asthma Advisory Group. We are honored to welcome Professor Christine Jenkins as she guides us through the critical steps needed to enhance asthma management at the national level.
Hello, everybody. Thank you so much for that introduction, and thank you for including me in your program. I'm really delighted to be able to speak here, in part because I'm on holidays after this and going to discover your country, which I'm very excited about, but also because we have really had a very fruitful relationship with Remedium One, helping us to recruit patients in some of our studies, and I'm very glad to be able to be here giving something back, something very small. I'm going to sort of take you to the bigger policy area and talk about how you do leverage government and how you can come together through gaps and concerns you have, which have been very, very well outlined for asthma here in Sri Lanka, and how you could collaborate to actually lobby your government to allocate resources and funding to achieve better outcomes for people with asthma. So first up, to start with just a general principles overview, some key points. You need to know what you're trying to achieve, and you need to keep that very clear in your mind throughout these processes. And we've already heard where the gaps are very nicely outlined for you. And those gaps are things that are very addressable. So think of this as a call to action for your colleagues as well as for the political powers that be, the ministers for health, their departments and the senior public servants that work in them. You need to go and talk to them and inform them. They will have their heads full of other priorities, and you need to bring it to their attention that there is a problem with asthma and that can be addressed. It's very important to have a group of you, people who are expert and committed and passionate about this. So look for some funding. Where could you get some funding? And I'll explain how we got funding for our asthma initiative. It's very important to know your country stats, to know what the burden is, to know what the impact of asthma is, for instance, to be able to enumerate how many people are affected. And we've heard about that very nicely, about the proportion who self-report asthma, and that gives you some leverage. It affects a lot of people. And then really identify things that you can do that are going to make a difference. So if those people end up in hospital and cost the country even more money, there are better ways of preventing those hospital admissions and deaths. As we saw in that 14-year-old, that's a tragedy. That's an eminently preventable death. And trying to put that to the politicians who care about money and resources as something where they can save money. It's not just for the good of the people who have asthma and the good of the country, but there's also political good in it in terms of savings. It's really important to have patient voices, and I'll explain to you how we have done that, because it's interesting, and at least in our country, patients often have more clout than we do as clinicians. But certainly as a team, you have much more potential for influence if the patients, the people who are going to vote for the politicians, actually are part of your initiative. Think differently. If things you've been doing aren't working, what do you need to do differently to ensure that that same old way of approaching things is replaced by something better? Establish some quick wins, things that you know are low-hanging fruit and that you could relatively easily achieve. And describe those wins in your proposal, in your document, in your blueprint, whatever you're planning to do, and how you might then evaluate it and show that there is real value. If you can show there's value, if you can show you've achieved things, then you have the capacity to leverage even more money or resources to achieve more. So in the case of COPD, I'm going to go through COPD in Australia and what we did, and then asthma in Australia and what we're doing. We wanted to transform what was happening with COPD. So we made an infographic. You can see that here. You can see how we were able to show that there was, I'm not sure you can see my laser pointer on here, no. We could show the burden of COPD. It was the third leading cause of death in Australia. It was very, very costly. It was also a condition that was potentially causing a huge number of preventable hospital admissions. So we could show that these were something that you could intervene in and reduce the burden of COPD in the hospital environment, where it is very, very expensive. And then we also showed that there was great discrepancy through the country. If you live in a high-income setting in a major city...
Yes, the laser, you can use it.
Oh, thank you. I now know how to use the laser. That's wonderful. So these were our different environments where you can see that there is a much greater impact of preventable hospital admissions in our major cities, much smaller than in our regional and remote areas. And we have many regional and remote areas in Australia. So showing that very grave disparity in care and outcomes was a really important thing. Politicians care about that. So we developed a national strategic action plan for lung conditions, and we focused it on 5 areas that we thought many people did not know about. For instance, prevention of COPD, of course, helping people not to smoke, but there are lots of other things that people didn't know about. For instance, we talked about COPD as something that starts at birth. The risk of COPD begins even pre-birth. And so we described it as a long-term issue that could, where there was intervention opportunity, even, for instance, preventing early childhood respiratory infection, reducing prematurity rates, reducing the need for children to be ventilated when they are born. These things make a difference because we know they're risk factors for developing COPD in later life. We talked about nihilism and stigma and the way in which that influences people's understanding of lung health. We talked about partnerships. We've already heard about team-based care and community-based care. That is really important. We talked about distributing the burden of caring for people across the health spectrum, not just for doctors. And we also talked about research and monitoring and equitable access. So these were kind of it was a new way of framing respiratory disease in Australia. And then we developed resources, and we have resources in terms of managing exacerbations. We have a concise guide for primary care. We have a pulmonary rehab toolkit, which you can actually deploy in very remote settings, a very, very low resource toolkit for pulmonary rehab. We've used this in studies with Indigenous people, helping them to participate in pulmonary rehab. We've used it in remote environments, and we know that it works. So we went away after we'd put our strategic plan for lung conditions together and said we've got to have some resources as well, and this is what we developed through our Lung Foundation. And we develop patient resources, and they are really important to help patients. We've already heard how patients don't realise that they can be better. They don't realise that there are non-pharmacologic interventions that can help them, and they don't know what to do when they have an attack, an exacerbation. So all of these things are available on the Lung Foundation website. If you just go to lungfoundation.com.au, you can access all this information. And self-management with QR codes. So for patients who are interested in knowing more about breathing techniques, in knowing more about physical activity, they can just use the QR codes. So what are the barriers to optimal patient care in COPD? This really gives us an idea about what we could be achieving. We know that patients and clinicians don't consider COPD as something that is truly treatable. They think of it as something almost in a palliative care kind of way. We've got to change that perception of COPD. COPD is about preventing worsening, preventing exacerbations, preventing hospitalizations, maximising physical activity, participation in the workforce and in families and social life. It's a lot more than just a disease that ultimately results in death. Misdiagnosis is a big problem. We've already heard about underuse and underavailability of spirometers in asthma. And poor utilisation of spirometry is a huge problem across the world, in high-income countries also, in not just in middle and low-income countries. So we had a big problem with this in Australia, then a similar problem in COPD. The patients just get given treatments without having spirometry. And as I said, poor utilisation of non-pharmacologic therapies, inadequate or inappropriate pharmacologic treatment, and underreported and unrecognised exacerbations. So there's a lot to potentially achieve, and this is an important thing about national blueprints and standards, that you outline what you want to achieve and where the gaps are. So we then moved on to a blueprint, transforming the agenda for COPD, and this is what we made the major themes. Lifelong prevention starting in early life, early and accurate diagnosis and risk identification, community-based management, and acute care management, and COPD research and translation. And each of these themes has a sort of an elaboration that enables people in policy and practice, say, in relation to this, to embed COPD risk assessment and the earlier identification of those at risk with COPD within Medicare services. So we aligned it with what is currently available for doctors to use and to bill for, so that it fits within their workflow. We've also then talked in detail about how this can be done, and maybe how you might assess lung function earlier in life than just when somebody first presents with breathlessness. And finally, that materialised through that blueprint. We lobbied government. We already had a blueprint. We launched it actually in Parliament House, and we invited the Minister for Health, and I was sitting on the stage with him, and he leaned over after he had heard about the blueprint and where the gaps were and what the needs were. We had already briefed him, and he said to me, whispering, would 10 million be enough? And I said, 20 million. And lo and behold, we actually ended up getting that amount of money invested in COPD, which seemed an impossible ask when we started on this journey. We had a lot of buy-in, and this, the Chronic Obstructive Pulmonary Disease Clinical Care Standard, is a standard for the nation now, and it was run by the Australian Commission for Safety and Quality in Healthcare. It was taken out of our hands. It involved many people who were very expert. We were totally happy about it, but it's what you can catalyse when you actually start a process like this at a national level, lobbying and articulating policy changes. Our quality standards are here, and they're now being embedded in things like agreements within local health districts for clinicians and administrators to ensure that these things are happening in their local health district, and not only to actually implement them, but to follow up and to evaluate them. So this is a nice paper. I just draw attention to it by Mohit Buhani, and it's really about how a global quality standard position statement is needed. But we've very much used this really as a sort of template for our national standards, and you could use it too. It's well worth reading. Care bundles are a tool that you can develop, and many of you might know about care bundles. They're sets of evidence-based interventions to improve the quality of hospital-based care at admission and discharge, and health professionals see them as positive. They're helpful for standardising work practices. They help you to see a clear pathway for patients. They enable transitions between different levels of care, hospital and community, and they enable post-discharge support to be articulated and written out for the patient and the clinician that they're going to see out in the community. And one of the things that really helps is having both or either a clinical champion and system-based initiatives such as financial incentives, or something embedded in your EMR that reminds you to write a discharge plan for this patient. Is the patient vaccinated? Has the patient been given smoking cessation advice? Does the patient know about pulmonary rehab or physical activity at home? These are the things that can be embedded in electronic medical records so that there is almost an automated process when you're entering the patient's discharge data. I must remember to do this to make sure they receive their flu or pneumococcal vaccinations. And a number of evidence-based bundles. Mark Miravitalis in Barcelona has written this paper, and it's about the way in which they've done this in Barcelona. This is their implementing an evidence-based COPD hospital discharge protocol, and he did a review on this. And they looked at patients hospitalised for an exacerbation, and they created COPD discharge bundles. And these were the 4 things they aimed at. So this goes to the issue of simplicity. Stay simple. You don't have to do everything at the beginning. Keep it something that's achievable, something that people understand, something that's going to get traction, and then work on the harder stuff. So smoking cessation, optimising inhaled meds, which means checking inhaler use, pulmonary rehab and continuity of care were the 4 things that they've articulated in their bundle. And in the UK, they've done this also, and this is a BTS admission and discharge bundle, and this is a paper about the use of this bundle. And they too found that it was really important to have these embedded processes in the system, things that actually help rather than hinder these bundles to be implemented. So a diagnosis of an acute exacerbation should be confirmed, an oxygen assessment should be undertaken, the patient should, if acidotic, receive treatment within an hour of admission, etc. So these are the sorts of goals you can set in your local environment. And then finally, the Canadians have done this amazing piece of work, which some of you may be familiar with. Chris Lixai is the author of this, but they've got a big team, and this is called Best Care for COPD. And what they showed was they dramatically reduced their hospital admissions, and with this integrated approach to COPD care in the community. They have luxurious levels of resource, which we don't even have in Australia. COPD nurses, they could make calls to their patients in the community, a whole range of things, but you can think about how you can tailor this to your environment. And they too have talked about tools for COPD care, and again, sort of these are the things that you can look at quite seriously, and I think potentially markedly improve outcomes for patients with COPD. And then reviewing it and seeing how you're going is so crucial. So now I'm going to just step aside and talk about asthma suddenly, and I haven't got a lot of time left. So this is something we have very recently done. We launched it at the Thoracic Society meeting in Perth in Australia just the week before Easter. And I've been doing this with a group of my colleagues, 6 of us all together. But I talked about how important knowing your stats is. So this is asthma prevalence in Australia. These are up-to-date data for all the different age groups. And you know, we often think of asthma as something that affects young adults and kids. But here what you're seeing is the high proportion of people aged 45 and over up to 75 and over that are still affected by asthma in our community. So directing care in that setting is just as important as in younger people. In Australia, we also know that overuse of SABA is a major problem. This is using EMR data and 720 patients, and people who took more than 3 inhalers a year per the EMR ended up being 28% of the patients with asthma. And of those, they experienced 2.5 times as many severe exacerbations and 4.5 times more likely to have poorly controlled asthma. And those who didn't receive a SABA script but got their SABA over the counter were also highly, highly likely to have more severe exacerbations, that is, requiring oral steroids and presenting to ED. So we know our own data. We also know from our own data these are oral corticosteroid dispensings. And what we know is that people who have a diagnosis of asthma and receive either an inhaled corticosteroid or a short-acting reliever, because they are taking oral steroids instead of receiving those medications, there is a much higher likelihood of diabetes and osteoporosis. So showing that frequent courses of oral steroids have consequences was another important thing we did. But perhaps the most important thing is to show that over time, the proportion of people in Australia who are experiencing poor control is getting worse, not better. From 2012 to 2021, increased numbers of people with not receiving a review of asthma, having an urgent visit, hospital ED presentation, spending a day at least in hospital, or having any urgent health care. All of these are features of more poor control. And we measured that against our asthma handbook goals. And here you can see 42% of adults with asthma, only 42% had taken any inhaled steroid in the last 4 weeks. 60% had more than 3 inhalers dispensed in the last 12 months. Only 17% had used an air smart regimen. And only 38% had had no exacerbations. 13% had had more than 1 course of oral steroids in the last 3 months. And only 28% had an action plan. So these are awful data, and this is what caused us to embark on our blueprint. Asthma's, as we've heard, such a treatable disease. Treatments are safe and effective, and we rank poorly in Australia also. We rank 3rd in asthma mortality rates. So we are doing badly, and we felt we had to do better. What were we trying to solve? These are our spirometry data. This is the pandemic, and these are claims for spirometry. They've never picked up to where they were pre-pandemic. We also know that asthma mortality is high by international standards, and we know that there is very, very low ownership of action plans. So we felt we needed a change in policy, systems, change in practice, and change in people's understanding of their asthma. So we got together. You'll recognise some of these people: Peter Gibson, Kerry Hancock's a leading GP in Australia, Vanessa McDonald's a nursing professor, and Philip Barden is part of the Severe Asthma Network in Melbourne. So all people who care very much about asthma and are very expert, and John Blakey is the clinical advisor to Asthma Australia. And so we articulated our vision, and it was to substantially improve quality of life for people with asthma, that some people would actually be able to achieve prolonged periods of remission, and that we even created an awareness that it was possible to have very long remissions, as well as reduce the overall burden of asthma in the community more broadly. So we had a big meeting initially with all the stakeholders. We got input about what to do. We consulted people with asthma through a Facebook recruitment process. We reviewed asthma models of care. We're going to publish this. And we looked at the Australian healthcare system and how we could align our recommendations with it. And then we put our blueprint draft back to the stakeholders, and we described to them what we hoped to do, and they had further input. So these were our priorities: reforming models of care, living well with asthma, transforming quality use of medicines, and implementing the optimal asthma consultation. We described how GPs could do an acute care consultation, an opportunistic consultation where the patient presents, say, whatever, with a sore big toe, or for their hypertension or their diabetes, a quick discussion about asthma, not just here's your asthma script, but something more meaningful, and also a full asthma review. And we aligned that with the ways that the fees are paid in Australia. So it's a call to action, and we've said in the blueprint, this is it, a bold blueprint for asthma reform in Australia. And this is our website, and you can go on the website and you can delve into this in detail. And I'd encourage you to do that, because I'm not going to have time to tell you all about it. But again, we enunciated the burden of asthma in Australia, and we did this because we believe this is mainly a document for policymakers. We want to change practice through funding, resources, and health system initiatives that can underpin the way clinicians care for people with asthma. So we've tried to really describe what living well with asthma is: not having any acute attacks, not needing SABAs, not requiring any oral corticosteroids, having minimal symptoms, and able to achieve and sustain short and long-term remission. And we've described what can be done with different types of models of care: team-based interventions, nurse-led asthma clinics, pharmacy-based care, and remote and virtual care, because we have a lot of places in Australia that are way, way away from anywhere that has metropolitan level services. This is our handbook, which also vividly now says, just as Gina says, no one starts on SABA alone. Everyone starts their asthma care on budesonide formoterol as needed, anti-inflammatory reliever. Then, if they need more, they step up to single maintenance and reliever therapy. They still take anti-inflammatory reliever as needed. And then in our system, they can step up their dose of SMART, but ultimately should be phenotyped and considered for the biologics which are available in Australia. So I'm just going to skip through and say that you need people for this. You need to come together. You need to think of the ways in which different entities that already exist, if you've got an asthma foundation, if you've got nurses and asthma educators who are interested, if you've got GPs who are interested, get them involved. It's not just something that happens top down. And then finally, I might just say that we are hoping that we will embark on a national patient charter for asthma, and also national standards for asthma care, just like I described has happened for COPD. And this would describe multi-professional care, the treatable traits framework, biomarker-led targeted therapies, and remission as an outcome. In other words, aiming high for asthma, not aiming low, not just controlling symptoms. We now know remission is possible. Now, not everyone can get biologics, but with optimal care, even with maintenance and reliever, we can truly achieve fantastic outcomes for people with asthma. And so that's where we're focusing our attention now. Thank you.
We are truly grateful for the time and expertise you have shared with us today, Madam. Now it's time for the token of appreciation. I would like to call upon Dr. Afla Sadikin, consultant chest physician, to kind of offer the token of appreciation to our speaker, Professor Christine Jenkins. We have a few minutes for questions. I now call upon our respected speakers, Dr. Niranjan Disanayaka, Dr. Vipula Bhattaduwarachi, and Professor Christine Jenkins to take stage. If you have a query, please raise your hand and the microphone will be brought to you.
Check. Thank you very much for all speakers for excellent presentations. My question is to Professor Jenkins. Thank you very much for the insights provided in initiatives about on COPD and asthma and your care packages and care bundles, which we will discuss in detail. Mine's more of a clinical question. Earlier, the speaker Vipula mentioned the difficult asthma phenotype in Sri Lanka. He said it's more female eosinophilic type of phenotype. In severe asthma registries in Australia, do your experiences match with this? What kind of phenotype? Because we are thinking of biologics and what biologics will suit us best. So what kind of information from your severe asthma registries in Asian cohorts, especially Sri Lankan cohorts, what kind of phenotype is emerging?
Thank you very much for that question. In our severe asthma database in Australia, it is predominantly adults, but I would say it's exactly as noted in Sri Lanka, that the eosinophilic phenotype is most common in children with asthma, with established asthma, not just preschool wheeze. We're talking about 6-year-olds and over. But as you get into adult asthma, in severe asthma, it's more of a spread with non-eosinophilic neutrophilic asthma and paucigranulocytic asthma being more common in adults, particularly in adults and women who get asthma as adults for the first time. So our severe asthma database is actually overrepresented with eosinophilic patients because that's how we started the database. We started it with people who we identified as being suitable for biologics. But since we've expanded it, we've seen that there is a greater proportion of adults who have non-eosinophilic asthma. And so on average, amongst adults, about 65% of patients with asthma are eosinophilic. However, I would just make a comment about, we did a study, as some of you might be familiar with, looking at azithromycin for people with asthma. And these were people poorly controlled on usually combination ICS-LABA at moderate to high doses. And we expected that the patients who would benefit would be the neutrophilic patients, not the eosinophilic patients. And what we found was it was both. So, it's true that targeted therapies obviously are targeted at eosinophilic asthma and T2 high. But in fact, some of the therapies we might normally, think were for non-eosinophilic asthma are in fact highly effective for them. But I also want to comment, I have quite a few Sri Lankan patients in Australia, and they have eosinophilic asthma. They virtually all have eosinophilic asthma, and ABPA is quite high prevalence amongst them. So that's something that I have really noticed about the Sri Lankan patients that I look after in Australia who have moderately severe to severe asthma.
Thank you, Christine. Is there time for one more question?
Yes.
My question is in Niranjan. Again, thank you for an excellent talk. About the MART approach and the dose differences. Now, when you take the formoterol budesonide preparation, the MDI has 4.5 and the DPI has 6 micrograms. When you are approaching, you're prescribing MARTs, should a distinction be made between the MDI and the DPI in terms of dose ceilings? And again, another question is escalation of care. Patients on the MART approach, if you need to escalate care or move on to the next step, what would guide you in terms of how MART approach usage and things?
Thank you, sir, for that question. Now, regarding the initial Sigma trial, they used a particular company's product, which has 200 by 6, but actually the delivery dose was 160 by 4.5. But most of the inhalers that we have in Sri Lanka at the moment have 100 by 6, 200 by 6, and 400 by 6, if I remember correct. And even whether they are MDIs or DPIs, except for that turbohaler that we have talking about, where obviously it is 160 by 4.5, it is mentioned. But most of them have this dose range, but the deliverable dose is equal almost. So in the 200 one, that is the understanding that I have. And the second thing is, I think probably the turbohaler and the metered dose, as well as a dry powder inhaler, delivers the same dose as I understand, especially in the 200 range. If you take, it depends on the puff that you take. And it is actually the recommended dose for anti-inflammatory reliever therapy, as well as maintenance and reliever therapy, as well MART therapy as well in step 3 and 4, as well as AR therapy in step 1 and 2. So that is a recommended dose, and depending on the dose, as you correctly said, we have in the AR therapy, in the initial stage, we take 1 puff as required in the mild, what we earlier call mild intermittent asthma. And in the mild persistent asthma, we usually take 1 puff in the morning or the evening of the 200 dose. In adults, I'm talking about. And then we use as required dose. It's almost like a MART. In step 2, now we are using. In step 3 and 4 MART, we use the doses accordingly, and we increase the moderate dose and to the high dose of what you call budesonide and formoterol combinations. So what would make me start on these patients in the appropriate dose step would be basically, I usually in the clinical practice, it's even suggested that we might have to start in the appropriate step, not to climb up the step in a gradual way, because I think that asthma is being an inflammatory disease. The escalation would depend on basically on the symptom control, the asthma control questions that we ask. And at the same time, rather than escalating at the onset, we probably might have had to look about whether we are using the correct inhaler for that patient and whether the drug is delivered in an appropriate way. And the second thing is whether the compliance is better in these patients. And I know that most of our patients are having poor compliance. And the third thing is obviously the comorbidities in Sri Lanka. I think sir will agree as well, we have a lot of rhinosinusitis with upper airway cough syndromes, as well as gastroesophageal reflux disease, and as highlighted, some fungal sensitization and ABPA as well. And the fourth thing is, unfortunately, in Sri Lanka, we have a huge amount of indoor air pollution due to biomass fuels, as well as other substances like house dust mite exposure. And if we don't try to treat them, it will be an issue. And sometimes certain drugs as well, using contaminately with asthma. So after we look at these, and probably when the patient is not improving, what I would usually do is to see whether I'm missing an asthma mimic. So basic investigations like chest X-ray and baseline investigation will be done. And if I'm confident that everything is in order, probably I might increase the dose frequency from the moderate, the low dose to the high dose, and see whether this patient is improved within about the next 1 or 2 months. And that is the way I usually do it.
So now, thank you very much for both of you all for the elaborative 2 lectures. I have one question on the mild asthma. Especially Dr. Niranjan was pointing out on mild asthma, where people are, the AR approach is going to be really important for those patients. Now,
is there any significance of patients' expectations when it comes to mild asthma patients and their treatment strategies?
Excellent question. I think in most of the instances, we can't forget the person behind the disease. And some of our decisions basically would change, even though when there is scientific evidence backing, sometimes we might have to change a bit depending on the person's perspective, expectations as well. So I think if I understand your question correctly, you're asking whether a person with mild asthma, whether they will like to take a long-term inhaler, something like that, or what are they trying to expect? Already they have according to them, have a low symptom burden, isn't it?
More than that, I feel that being in subcontinent, our patients' expectations are very low, especially with symptoms. And they don't expect much of, they are quite happy to have those symptoms and continue with their day-to-day works.
Yeah, but I think I agree completely, because depending on the social, some people, get affected more, probably especially in a person who is a 28-year-old working in a bank and cannot stay in the air conditioner because he's having regular symptoms, and comparing it to a person, maybe a 65-year-old staying at home, which they might tolerate these symptoms much more. But I think as medical professionals, we might have to look at the underlying issue in the lungs of these patients, because even though at the moment they might be mild and both may have perceived the disease in a different way, there is this inflammatory process that is going on in the lung, and probably they might go into step 3, step 4 and beyond, especially because of the persistent inflammation that is there in the lung. So there, I think if we can convince the patient, even though you have what we call, I don't use the word mild disease, maybe asthma that is probably infrequent and you don't have symptoms, but the inflammatory process in the lung is probably going on, and maybe that, and your lung functions. And it has been shown, even with air therapy, in this group, it is beautifully shown that the lung functions are deteriorating and their asthma control is poor. So that is why I think even with air therapy, probably we might have to select a subgroup of people from air therapy for continuous budesonide inhaler therapy. How do we convince them to take treatment? Maybe we might have to use some objective evidence like the FeNO or the eosinophilic count, which might have a high risk of exacerbation and poor lung functions in the future. Then they will say, your FeNO is this, so you will benefit more. So that might be a strategy that we can use. Yes.
I might just add to that. I'm probably not as worried about lung function decline in this group of patients. I think that the majority of these patients, if you ask them, if they think of themselves as being mild, they will not want to take day-by-day therapy. So the alternative to anti-inflammatory reliever as needed is day-by-day ICS or MART. And most of them are non-compliant because they consider their disease is inconsequential. So I agree with your question. I'm not even sure, I don't think we should use the term mild. I actually think that it's harmful in terms of patients understanding. They believe, okay, it's inconsequential, I don't need to worry. But we know from the National Review of Asthma Deaths in the UK, and we know from data you showed very nicely, that some of these patients don't do well. If they start on anti-inflammatory reliever, they just step up as they get more symptomatic, and then they get into regular therapy, which is going to be good for them. Whereas if they're taking SABA as needed, that's never going to be good for them. In fact, as they start to take more, it's going to be worse for them. So, I think, again, accepting patient behaviour is part of getting this right. And patient behaviour is, I don't want to take a regular day-by-day treatment if I think I don't need it. But helping patients to take something when they have symptoms, say those symptoms are telling you there's inflammation, there's trouble ahead. So take this medication, which is going to cut into that trouble, and you're not necessarily going to get any worse if you take this. You're going to actually have a lesser chance of an attack. I think that is what they care about, the immediate few days rather than the long term, which is always hard to argue with patients, especially young patients. But if you can prevent an attack, you can prevent worsening of symptoms so that they can't do something they desperately want to do, play soccer on the weekend or whatever, that's great. And they can get hold of that idea very easily.
I would like to once again thank our respected speakers, Professor Christine Jenkins and Dr. Niranjan Disanayake, for taking the questions from the audience. Now it's time for the tea break. Please take this time to refresh yourself and reflect on the insights shared so far.
Good morning, everybody. So first of all, I would like to thank for giving me this opportunity. My topic today is difficult and severe asthma when standard therapy is not enough. So I have prepared this lecture to clarify a few concepts, basically. So let's see what I'm going to cover. I don't have any conflicts of interest. So my lecture outline is this. So I'm trying to clarify what is difficult asthma and severe asthma. And I will explain how to assess patient with difficult asthma. And then we'll be taking you through what is asthma phenotype and how do we do it, and what are the main types of biologics, and the few important points about it. And we'll briefly discuss about asthma team, how do they work, right? So we'll start off with this small case history. So you have got a patient, 71-year-old lady with asthma, referred by GP with following 3 courses of oral steroid in the past 12 months. So currently she is on GINA 4 medication, Symbicort 206, 2 puff times a day with LAMA, right? So what is difficult asthma? So GINA defined difficult asthma as uncontrolled asthma despite being on GINA step 4 or 5. So 4 or 5 include this moderate steroid inhalers with add-on therapy and also high-dose steroid inhalers. So it's surprisingly common. It affects nearly 20% of asthmatics. What is severe asthma? Again, GINA defines severe asthma as uncontrolled asthma despite being on high-dose steroid inhalers or oral corticosteroid. But there's a difference. So this patient with severe asthma, we have assessed, corrected all the contributory factors, and also this patient is being on good adherence to treatment, right? So severe asthma, so we have only less than 5% of adult asthmatics. So we observe severe asthma in only less than 5% of adult asthmatics, right? So let's see why this difference. So you get a patient with difficult asthma. Most of the time, respiratory physician will see a patient with difficult asthma. So what do we have to do? So first we have to confirm the diagnosis. So the confirming diagnosis, I think already must have been discussed. And if we can't confirm the asthma diagnosis, then we have to look for alternative diagnosis. And after that, if we can confirm the asthma diagnosis, so the next would be looking for comorbidities, right? And same time, we have to look for this inhaler adherence and techniques. So while correcting those, if we identify any asthma comorbidities, then we have to treat asthma comorbidity first. And then the third step, so having corrected this as confirming the diagnosis and looking for asthma comorbidity, and also correcting this inhaler adherence techniques. So we have to move on to we can diagnose severe asthma. So I noted some spelling mistakes in my slide, and sorry about it, right? So as you can understand, so the difficult asthma, when we see a patient with difficult asthma, so difficult asthma patient is not always severe asthma. So severe asthma is a subgroup of patient of this difficult asthma, right? So that's why difficult asthma, we do observe about 20% of asthmatics, but we do observe only 5% of asthmatic as severe asthma. So when you get a patient, so let's see what happened to our patient. So as I actually explained, So these comorbidities are very important. So we have to, I'm not going through each and every one, but these are the common comorbidities we observe in our asthma patients. And then we will, after correcting those comorbidities and looking at inhaler techniques and compliance, and then we do diagnose the severe asthma. Right, so what happened to our patient? So this patient, when we take the history, we realize the patient is having voice change associated with respiratory symptoms, right? So we did refer to ENT assessment, and unfortunately, the patient was diagnosed to have laryngeal cancer. So now I hope you can understand what is the difference between difficult asthma and severe asthma, and also why it is important to clearly follow these steps before coming into diagnosis of severe asthma, right? So let's move to the second half of the lecture, the second part of the lecture. So this is asthma phenotype. So what is asthma phenotype? So a phenotype is observable disease pattern. So it is what we see clinically, right? So why it matters? So it helps understanding disease behavior, and it also guides selection of most appropriate treatment. So just to highlight, even if we don't have access to biologics, asthma phenotyping is important. So it can still guide our management and also guide the behavior of the disease. And what is endotype? So everyone is talking about endotype. So endotype is what is behind this phenotype. So it is how this happened, right? So let's go to the next slide. So this slide shows you this crowded slide. I am not going to explain anything. Just to explain the word endotype, I have put these slides. Right. So asthma phenotype, there are two major types: T2 high asthma and T2 low asthma. So what do you mean by T2 high and T2 low is, so we are talking about this type 2 inflammation in airways. So T2 high and T2 low asthma, how do we identify? We'll talk in a bit. So there are, we can subcategorize, subphenotype. So T2 high asthma, we do have three main subtypes. So early onset allergic asthma, late onset eosinophilic asthma, and mixed phenotype. And T2 low asthma, we do observe neutrophilic asthma and post-granulocytic asthma. So how do we do this phenotyping? So asthma phenotype assessment include investigations as well as clinical assessment. So I mean, everybody must have heard about these biomarkers. Biomarkers are very important when it comes to phenotype, right? So the gold standard asthma biomarker, gold standard test is sputum cytology, but in clinical practice, we hardly use this sputum eosinophils for phenotyping. So most commonly used biomarkers are blood eosinophil count and sputum, the FeNO level, which is fractional exhaled nitric oxide. In addition, the patient's total IgE and the RAS level and skin prick test will be helpful in further categorizing of identifying the specific phenotype. So when it comes to T2 high and T2 low asthma, blood eosinophils and the FeNO levels are the most important two biomarkers we use commonly, blood eosinophils and the FeNO levels. So the clinical assessment is also important. So history examination, we should focus onset of the disease and allergic history and comorbidities. So let's look at how we are going to do the categorize, or how we are going to phenotype this asthmatic patients practically, right? So we do this, as I said, these blood eosinophil and FeNO levels, which are very simple investigations, widely available investigations. So those are the only two things we need for this phenotyping. I think in that way we are very lucky because we can establish these things widely and then we can do the phenotyping, right? So when you have a patient with severe asthma, so we do this eosinophil count and pheno. If eosinophil blood eosinophil count is more than 150 and pheno level is more than 20, so we can categorize it as T2 high asthma. But what if they are low? Can we say it is T2 low? So this is very important point, right? So if it is low, we should not jump and say it is T2 low asthma. We should make sure to repeat it. We should make sure to repeat it because these severe asthma patients, they are on high dose inhalers and oral steroids, so which can mask these biomarkers. So it's very important to do repeated assessment of these biomarkers before we concluding this is T2 asthma, right? So, and then to further characterize, so phenotyping, we do need all these assess all these clinical characteristics. So because we are going to talk about T2 high asthma in other slides, so I'll be just say a few things about T2 low asthma. So the absence of low level T2 inflammatory biomarkers, that's this blood eosinophil count, and the pheno level suggests T2, we can diagnose T2 low asthma, right? So there are few clinical features, the adult onset asthma and poor response to these inhalers and as well as the corticosteroid would suggest T2 low asthma. And also, so there are some associated factors that if the patient is smoking and obese, and if the patient is having psychological issues, anxiety, depression, that points to the T2 low asthma, right? So there are two subtypes. So you can see neutrophilic and postgranulocytic asthma. So in that case, for this, mostly we need some bowel cytology or sputum induced sputum samples, right? Right. So let's look at the most important, I think, the part of the lecture, so the biologics at glance. So biologics indicated in T2 high severe asthma. So we do have a patient referred to us with difficult asthma. And then now we have assessed everything. We have confirmed the diagnosis and we have treated comorbidities and we have corrected the inhaler technique and inhaler compliance. And now we do have a patient with severe asthma, so who might need biologics. So let's see what type of biologics we have, right? So before understanding biologics, it's important to go through this, have some understanding about the molecular mechanism of the biologic, right? So this represents the airway epithelium of an asthmatic patient. So when airway epithelium get exposed to these irritants, pollutants, allergens, so it will start secreting these epithelium alarmins. So if you can see, these are interleukin 33, interleukin 25, and TSLP, which is very important, thymine stimulating lymphoproliferation factors, and also these alarmins will stimulate T helper 2 cells and antigen presenting cells. Together, they will secrete interleukin 4, 5, and interleukin 30, right? So we should focus on this interleukin 4, 5, 13, as well as TSLP, because they are very important in biologics pathway. So if you can see, these interleukin 4 and 13 will stimulate the B cell sensitization and production of IgE, which is going to be a major step in allergic asthma, right? So, and if the interleukin 5 will mainly stimulate the eosinophilic pathway, which is predominant in adult onset as eosinophilic asthma. And also, if you can see, this IL-13 is another important interleukin in asthma, so which will activate this epithelium and then increase the secretion of nitrous oxide, which we are measuring when we are doing the FeNO level, right? So, and also it will affect in airways, and then it will increase the airway hyper responsiveness and mucus production as well. So if you consider a patient with asthma, so all these processes are ongoing, but some parts of this process predominant in some patients. So that's why we do this eosinophil and FeNO levels, and then see, we first confirm they have T2 high asthma, and then secondly, we do have to identify which of these pathways are predominant in their disease to target the correct biology, right? So early onset allergic asthma, so this IgE pathway is predominant, and then adult onset eosinophilic asthma, you can see this eosinophil pathway is predominant, and in clinical setup, we always do C mix pattern. So it's not easy to categorize or phenotype as we do see in the slide. So let's look at this, look at the next slide. So please focus on this square, if you can see. So this, the very first biologic introduced was like omalizumab, right? So it is anti-IgE. So if you can see now why it is mainly using in allergic asthma, right? So it's, so early onset allergic asthma, this pathway is predominant. So because of that, omalizumab is using in allergic asthma. So the second important biologic is anti-IL-4. So if you can see this, anti-IL-4 receptors are present in B cells. So these anti-IgL4 receptors bind IL-4 as well as interleukin-13, which activate this early onset allergic pathway. So dupilumab can be used in allergic asthma. In addition to this allergic pathway, as I explained to you before, this interleukin-13, which is again acting through this IL-4 receptors, will increase the nitrous oxide production and airway hyperresponsiveness. So this interleukin-4 is important in play a role in both allergic asthma as well as eosinophilic asthma. So because of that, this dupilumab or anti-IL-4 receptor blockers, they can be used in both early onset asthma and adult onset eosinophilic asthma, depending on the the patient presentation, right? And next biologic is this interleukin-5 blockers, right? The anti-IL-5 antibodies are the mepolizumab, and the newer one is this resliximab, which is not very commonly used, right? And we do have like two types of IL-5 related biologics. So the other type is this anti-IL-5 receptor antagonist, which is benralizumab. So in eosinophilic asthma, these biologics are more important. So now, so if you can focus on this purple color square, purple color box. So this is the tezepelumab. This is again, this is anti-TSLP antibody, which will prevent this the whole process by acting on TSLP. So if you can see, that can prevent all these, that can inhibit all these cascade of events because it acts more peripherally, right? So it can be used in most of the phenotypes. Right, so I'm not going to talk about all the biologics one by one. Just to, this is just a table of biologics. So you can see this anti-IgE, so we, and the anti-IL-4 and the anti-IL-5 biologics, 3 biologics, and this is the anti-TSLP biologics, right? So just to draw your attention to frequency, so the most of the biologics, we have to give once in 2 weeks or 4 weeks. But just to draw your attention to benroluximab, so initially we can give it like once in every 4 weeks, but then later we can move to once in every 8 weeks, so which will be like beneficial in professionals, right? So it's we can use it less frequently. So what are the eligible requirements? We already discussed. Just to highlight again, omalizumab mainly in allergic asthma, and dupilumab. So we can use in both allergic and eosinophilic asthma, depending on the patient's presentation. We'll be discussing about that later. And these are the anti-IL-5, mainly in eosinophilic asthma, and tezepelumab, we don't have any specific biomarker threshold. And just to, so when you are taking the history of the patient, it's important to identify these associated diseases, because these biologics are also approved in these conditions. So if that patient is having one of these conditions, so then it would be, so then that also important in deciding which biologic patient needed. And effect of biologics, this the summary of the effect of biologics. So all the biologics do reduce exacerbations, and also it do reduce, like it will reduce the maintenance of oral corticosteroid and improve quality of life. And importantly, FEV1 improvement we do see mainly in dupilumab and tezepelumab, right? So that is important in taking clinical decisions. Right, so what are the predictors of response to biologics? So the predictors of good response would be higher exacerbation and raised eosinophil count and elevated FeNO levels. So the poor response for most of all the biologics will have the poor response to patients with high BMI and fixed airway obstruction. So these are the key factors we should consider. We should consider before selecting biologics. So asthma phenotype, as I said, like it's very important, and the levels of biomarkers, we do need to look into that. We'll discuss few cases and then realize why. And then the lung function test, whether it is obstructive or not, is very important. And the comorbidities, which are influencing the choice, and the patient factors like ability of self-administrating the drug, and lifestyle and working commitments and things. Those things are also important, right? So let's let's go through this case, right? So 55-year-old lady with recurrent asthma exacerbation with recent history of acute asthma exacerbation, referred to difficult asthma clinic due to persistent asthma symptoms. So as you can see, asthma control test shows, it shows the poor asthma control, and then she did have 3 exacerbations in 12 months. So she had childhood asthma and also nasal symptoms with anosmia. So when she came, she was on high dose nasal steroid. Right, so lung function test showed the obstructive pattern spirometry with elevated FeNO level of 111 and blood eosinophil count of 200, which is again elevated, and then elevated IgE level, and allergic testing also showed positive results, right? So ENT review confirmed this chronic rhinosinusitis with nasal polyposis. So we switched inhalers to high-dose Trimbo, and then we continue for about 12 weeks, but patient continued to have 2 more exacerbations. So then we refer this patient to biologics, right? So let's see, when we are going through, as I said, so we have to say whether this is early onset or not. So the history is important. This patient had childhood asthma, so early onset, and the allergic asthma, because this patient had the positive RAS test, elevated IgE, right? And then thirdly, she also had this chronic CRS NP, right? So an airway shows obstruction, FeNO is high, and high eosinophils were there. So when it comes to allergic asthma, so we do have two options. So what is the best treatment for this patient? Omilexumab or dupilumab. So if you can remember, so this dupilumab showed this good response to SPV1 improvement, right? And also if you can see this diagram, you can see this dupilumab, it has effect on anti-IL-13, which increase the phenotype. So because of that, this patient was commenced on dupilumab because it is more beneficial in patients with allergic asthma with high FeNO. And when you have the CRSNP, and when you have, as I said, early onset allergic asthma and impaired lung function, especially because omalizumab will not have impact on this impaired lung function test. So let's discuss another quick case. I think I'm running out of time maybe. And so there is an 18-year-old male coming with, who already diagnosed with childhood onset asthma, who's having hay fever, referred to difficult asthma clinic with persistent breathlessness, right? And wheeze and cough. He was very symptomatic. And he was treated for about 4 to 5 exacerbations with this steroid. And he had he had to actually stop his work as well because he is very symptomatic with asthma, right? ACT score was 14 and he was waiting. When we saw him, he had this, he was on this moderate Symbicort with Spiriva, which is LAMA. And it shows, examination shows bilateral wheeze. So just to quickly run through again, she had obstructive spirometry with very high FeNO level of 213 and very high eosinophil level. And also he showed evidence of allergies, I mean the atopy with positive house dust mites and grass pollen positivity. IgE levels were high. So we change over inhaler to high dose steroid, Symbicort 412, and then continue with LAMA and corrected, the treated comorbidities, and then still he was like very symptomatic, needing oral, having exacerbation while on this treatment. So then we refer to MTT. So what would be the most suitable biologics for this patient, right? So, so to summarize, this gentleman had early onset asthma with atopic features as well as very significant eosinophilia and high FeNO levels with evidence of airway obstruction. So I think it's not difficult to decide what we have to give for him. So as I said, so because he has the most of the pathways in his his asthma cascade are activated, as evidenced by high FeNO, high eosinophils, and then high IgE. So the best would be tezepelumab, right? So the patient was started on tezepelumab, and then so it is. So these are the few facts. Like when you have multiple race biomarkers and mixed pattern with like allergic and eosinophil both patterns and ARV hyperresponsiveness with impaired lung function test, so this biologic would be a better option. So quickly run through another case. So again, this is a 53-year-old asthmatic, right? With the recent history of ITU admission. So lung function test, no obstruction, but showing high eosinophil count and FeNO level. No evidence of allergy. So corrected inhaler techniques and compliance, continue to be symptomatic. So this gentleman is diagnosed with adult onset eosinophilic asthma with mild FeNO of mildly raised FeNO, no airway obstruction. So it's adult onset eosinophilic asthma. So the anti-IL-5 or anti-IL-4 anti-IL-5 targeted therapy is the most reliable or most effective treatment. So when you can choose anti-IL-5 treatment when the eosinophilia is predominant more than the FeNO levels. So especially when the blood eosinophil count is more than 500. So this will have good effect. And higher the exacerbations, it will have more response, more good evidence. And then the steroid dependency and adult onset asthma, as we discussed. So this anti-IL-5 and anti-IL-5 receptor antagonist would be important in that. Right? So in this patient, it was concluded to start benralizumab because it is less frequent, and in professionals, they tend to start on benralizumab. So this is again the diagram just to show you. This is where the eosinophilic predominant pathway. We can use this anti-IL-5. So right. So I think with the time limitation, I will quickly go through. Quickly take about 5 more minutes, right? So this is a new concept. So the magnet and bomb concept, I thought of just introducing that because it's very interesting. So you can go through this article if you are interested to know more about it. So they consider if the nitrous oxide level in the epithelium is act like a magnet, which will recruit blood eosinophils, right? So the magnet is this FeNO, nitrous oxide in the epithelium, and the bomb is eosinophils in the blood. So then the nitrous oxide will pull these eosinophils to the airway and then activate the whole inflammatory process of this airway, right? So the important point here is when we see a patient with T2 high asthma, we should see whether this patient is magnet predominant or bomb predominant. That means whether FeNO predominant or whether it is eosinophilic predominant, because the biologic treatment would be different. So if it is FeNO predominant, as we discussed, the anti-IL-4 or dupilumab would be more helpful, as well as the tazepilumab, because it is acting more peripherally. It also has good effect on FeNO, right? Anti-IL-5 always be helpful in eosinophilic asthma. So these patients with very high FeNO levels and the patient with very high eosinophil levels, so they do call hot patients. So these patients are like have very tendency to deteriorate quickly, and then we have to identify these hot patients and treat early, right? So just to tell you how does it look like tertiary care center, right? So it's always multidisciplinary, like a team-based care. So there would be a day case review when a patient is referred to tertiary care center in tertiary asthma unit in tertiary care center. So usually there will be a chest physician, asthma specialist, an asthma nurse specialist, and chest physiotherapist and physiologist. So patient will have the lung function test and FeNO, and then with the results, patient will go to the chest physician, asthma nurse specialist, first asthma nurse specialist, and they will go through the mainly in her compliance techniques and everything, and update the chest physician, and then chest physician will be going through the history, detailed history examination, and then if necessary, they will ask patient to, they will refer patient to physiologist. So on site, the first 4 people will be on site. So the other people, depending on the requirement, will be referring to speech and language therapist, psychologist, ENT team, and there will be a pharmacist for working with asthma team, especially when we prescribe biologics, and there will be dietitian to help with the obese people. So the secondary care center, so they do have mostly asthma specialist, chest physician, and asthma nurse specialist and physiologist. And the other team members would be through referral pathway. So in secondary care unit, we do say difficult asthma patient and then identify severe asthma, and they will be discussed in local biologics MDT and refer to regional biologics MDT for to discuss which biologics would be the best biologic. And when to refer to biologic MDT is another question, I think. So we have to make sure first, as we discuss, severe asthma is not difficult asthma. And then we have to have at least 3 steroid courses over last 12 months or continuous steroid usage in last 12 months. So importantly, these patients has to be on high dose steroid at least 12 weeks. At least at least 3 months. I think the GINA says it 3 to 6 months. So practically, when we do refer, at least we consider 12 weeks of high dose steroid inhaler to make because in regional biologics MDT, they do always check on this whether the patient has been on these high dose steroid inhalers, right? So just to so I think I have discussed all my topics now. This is not actually something. I mean, what it didn't come from me actually. So this was like one of the biologics pioneers, Professor Ian Parvard was mentioning about, when he was talking about biologics, he said about this. So in rheumatoid arthritis, so we do observe this if we pick up patients at the early stage, so the hands will be like this, and then we can treat biologics. But if we detect them at this stage with chronic rheumatoid arthritis changes, so the biologics will not have place. So he applies this principle to asthma. So even in asthma, if we detect these hot patients with T2 inflammation without airway obstruction, so then the effect of biologics would be more, right? So the message is never wait till airway obstruction develop to treat asthma. So detect early and act early. So thank you. So sorry to load you with lots of information, but I hope this has been helpful.
On behalf of the organizing committee, I extend our sincerest gratitude to our respected speaker for that outstanding presentation, madam. Up next on the agenda is session 5, Managing Childhood Asthma to Tackle Adult Lung Diseases, Insights from Pulmonary Function Test Trajectories. I take great pleasure inviting Dr. Channa De Silva, Consultant Pediatric Pulmonologist, Lady Ridgeway Hospital for Children, who will highlight the key strategies for managing asthma in children.
Very good afternoon. So within next half an hour, so I like to stress important new concepts, actually not new actually, but sometimes may be new to us, but importance of addressing these issues during the childhood to prevent development of some severe significant problems during the adulthood. As I already know, the asthma is the most common chronic disease in childhood. Still, a lot of children, not only Sri Lanka, worldwide, suffering from asthma because of this chronic persistent disease. Now, there's some arguments, some concepts are developing. So this asthma impact, it's not only for the childhood, but how it's affect the adulthood as well. So what's the progressions, what's the role of this pediatric diseases, pediatric respiratory disease, especially asthma as a predisposing factor, so all the disease, so adult disease, especially COPD-like conditions. We discuss about asthma as a singular word, but it's simply asthma or asthmas. Yeah? As we know, asthma is just an umbrella term which describes the cough, wheezing, that's some sort of a syndrome. It's like anemia, which describes low hemoglobin, or arthritis, just discussed. So, as you know, under the terms, under the umbrella of anemia and arthritis, there are many different conditions. So, asthma is exactly like that. It's not a single disease, it's a heterogeneous disease. Under this umbrella, there are different types of diseases which already Dr. Prasanjali discussed. asthma symptoms, asthma syndrome, with these clinical presentations, there are different types of identifiable clusters of clinical presentations, what you call these phenotypes. These phenotypes are derived because of these endotypes, different biological, pathophysiological mechanisms, which just shown about identifiable biological mechanisms, but still we don't know what are these exactly different types of mechanisms. As we know, this T1, T2 mediated or the T2 high or T2 low, but it's not the comprehensive. Still, ongoing researches are going on to identify what are these exact types of. It's not a simple disease, that's the problem. So various factors are involved from the fetus to adulthood, especially the initial phase. It's a genetic factors which involve, especially antenatal, and going on with the lot of environmental interactions. So the initial first wave, which mainly genetic factors are important for the development of this asthma in children. And later, the second wave, the environment factors, genetics, and then the epigenetics. So these DNA methylations and various new mechanisms. So now the studies are going on to identify this molecular level, why these things happen, specific identification of specific types of mRNA, especially the markers of this deterioration, especially as just discussed, some patients with uncontrolled or severe asthma patients, especially these are the groups which finally lead into the COPD and chronic diseases as an adulthood as well. So this is the normal progressions of lung functions as children. Gradually with the growth, the lung functions, the parameters will increase and up to a maximum level at the mid-20s, and then physiologically there is slow deterioration of these lung functions. This is a normal achievement of, and then gradual deterioration of these lung functions. To achieve this, to maintain normal lung functions, to have a normal lung growth or have a normal respiratory health, the lung function should be normal at birth, and there shouldn't be major events during childhood, and the rate of physiological decline of these lung functions as adults should be normal. But unfortunately, these three all requirement doesn't happen in most of the times. That's why these trajectories become abnormal or sometimes deteriorating and finally end up with significant severe diseases like COPD. Now there are emerging evidence, especially over the last decades, how these childhood conditions, childhood respiratory disease, especially asthma, affect the adult diseases. Like so childhood asthma is being functioning as a risk factors for the development of chronic diseases. So this is one of the important, this Michael, J and team. So they have actually, we don't have to go to all these studies, but I just show some important studies and special summaries just to elaborate, just to show, just to illustrate how these new concepts are important and how the asthma management, proper management, childhood is important to prevent or at least to reduce the burden of these adult diseases, especially COPD like chronic diseases. So they have mentioned, this show that asthma is associated with reduced lung functions, which may start in infancy or prenatally, even prenatally, before birth, persistent through childhood, adulthood, and predisposed for early or more severe COPD. So this is a problem. So that's why it's important to focus on, say, more studies, more reviews are appearing on this. So this Eric and team, in their paper, they have mentioned that impaired lung functions early in life is associated with later chronic airflow limitations or even COPD. So this risk seems to particularly strong in subjects with persistent and severe forms of childhood asthma. So that's why it's important to tackle this severe asthma, achieve the control, treat as much as possible and achieve the control in early part of the life before this going as a long-term conditions. So today we are focused on this lung function trajectories. So trajectories, these days the world is focusing on Middle East to assess these trajectories of missiles going from country to country or the continent to continent. So next few minutes we are focusing on this lung function trajectories, how the lung functions move or change according to the age. But unfortunately, there are some missiles happen or act against, especially the asthma attacks, uncontrolled asthma counter missiles, which change the direction of these normal trajectories. So that's a problem. So we see what are these factors which affect these normal trajectories of lung functions, getting peak around 20s, mid-20s, and gradually decline with the aging. This one of the important landmark paper assessment of lung function trajectories, this Australian Tasmanian longitudinal study. They have identified, they have arranged this follow-up for almost 6 decades of over 2,000 people, and regular intervals they did lung functions. And with that, they have identified from 1968 to 2015 6 types of different trajectories, lung function trajectories. You can see this is a normal, the persistently high, this is going above the normal level. Some groups about 12%, and early low, and then little bit of accelerated growth and growing as a normal lung functions. And the average, the persistently going above average level, but not very high level. But these are the important things. Below average, starting below average and persistently going below average. These are the vulnerable groups of patients, initially children with low lung functions, and this group, you can see persistently low lung functions throughout the low, and this last group, early average, but gradually significant decline, significant reductions in the later part of the life. So, and with this, they identify the possibilities of COPD in these patients. You can see the last group, obviously with the COPD lung functions declines, with that reflects the significant proportions of this group which early decline of lung functions, and later also then the higher, very higher risk of almost 50% of them had COPD during the adult life. As another study, this was done in New Zealand, Dunedin study. This again, regular follow-up and assessment of pulmonary function. The initial study they assessed mainly published about the FEV1 value, but this study they have assessed all the important spirometry parameters. And they have identified this childhood asthma and airway hyperresponsiveness, which evidence with the bronchodilator reversibility or methacholine challenge test is significantly associated with the development of later chronic lung diseases. And they have identified 10 distinct trajectories of their cohort. You can see, again, similar phenomena. The people who have started with low lung functions due to various reasons, antenatal, perinatal, during childhood, and as they are doing persistently with low lung functions, and they are the people who has very high chance of developing chronic obstructive disease, airway diseases, or COPD. They are given the names, so I don't, there's time to go in each and every place. And the other, not only the FEV1 parameters, they have identified the FVC, almost it's parallel going, and the FE1 to FVC ratio. So what is the implications? What's the important parameters is going? And they have assessed the predictors of every different trajectories. So childhood airway hyperresponsiveness and the tobacco exposure later around 45 years of age, and the BMI, the obesity. These are the important factors they have identified which associate with the persistently low trajectories of this, even with the FEV1, FVC, as well as the ratio also associated with this. So in this study, they have identified this most trajectories are approximately 5 parallel. What's that indicate? That's indicate during childhood starts with the low lung functions. It's going almost in the same way without crossing. That means the catch-up is significantly low. So that's why it's important early part of the life to identify, to address these children with low lung functions, and already established before adults. So this is one of the important things. The trajectory, the path, the way that their lung growth is already established before they become adults. So as adults also, they will continue to have very low lung functions if these patients, if the children, if they start with the low lung functions, so they hit their the lung growth during that period. So that's one of the important identifications. And it's another study published in Thorax little earlier, 2014. So again, this is another cohort, Melbourne asthma cohort. They have identified, they have followed up these patients since 1957, both cohort. Every 7 years up to 50 years of age, they have assessed these patients. So they have identified in comparisons with children without asthma at 7 years. They have started this study at the 7 years of age at these people, now up to 50 years of age. Children with severe asthma had an adjusted 32 times higher risk of developing COPD. And so these are the trajectories they have identified, the normal about and persistently low and even further decline of these lung functions associated with these patients. And then later they develop COPD, obviously the lung functions become further decline. So these are the risk factors. They have identified some statistically significant factors. Asthma. So asthma is one of the important risk factor, with especially the severe asthma and some other diseases, other conditions, and especially the exposure to the tobacco. Yes, obviously. So the asthma and these conditions are not only the conditions that lead into COPD. You can see here. So even with the normal lung functions, they can have COPD. That's obviously another group. And the normal lung functions, they can continue as normal. Even with initially impaired lung functions, they will continue as normal. But importantly, the low lung functions, if they develop, if this disease progresses to COPD, so they have the worst prognosis, they have the worst outcome with the lung functions. This is the important thing. Small lungs lead into COPD, so they will get the worst outcome as adults with further decline in lung functions. So important message with the identification of the risk factors of these trajectories is, yes, if the lung functions values are low during early childhood and adolescence, and then it's most of the time continue as low lung functions in adults, and that one of the important predisposition or maybe the precursor. Obviously, there are many other factors, but one of the important thing to develop COPD in adults, if the lower the values, the higher chance of developing COPD or progressing it as a chronic disease as in adults as well. So what are these risk factors? They have identified with these the cohort studies and some other studies. So initial low lung function, that means at birth, since birth they have, at the time of birth, low lung functions due to antenatal factors, even maternal smoking, maternal nutrition. These type of factors are important to have a proper lung development and have a normal lung at time of birth. And then sometimes they have the male sex. So recurrent ways, one of the important topics for the today, allergy sensitizations, air pollutions, tobacco exposure, active or passive both, and then other conditions of which hit or affect the respiratory health of these patients. So how these mechanisms, what are the mechanisms, how these lung functions declines, why these patients with this type of conditions, so uncontrolled asthma or some other environmental factors lead into development of this COPD or having persistently low lung functions. Yes, various mechanisms I have explored, and some of these were tested and some new sophisticated research particles. So now they have publishing, the evidence is accumulating. There may be oxidative stress, as we all know, leading direct damage to these airway epithelium, and some proteases, imbalance between the antiproteases and the proteases leading to direct tissue damage. And the inflammatory response, obviously, as Dr. Prasanjali mentions, the T2 predominant and the T2 less inflammatory process, especially different types of interleukins, inflammatory markers, cells, all these things are important. And airway fibrosis and remodeling. So remodeling is one of the important figure. As you know, this GINA, the definitions, it's initially the asthma is a reversible disease. The airflow limitation is a variable, but if you don't treat it properly, the remodeling, sometimes these airflow limitations would be permanent or persistent, and that's one of the important factor leading to COPDs, these patients. So in airway remodeling, so if we do not identify asthma properly, if we do not treat properly, if we do not use steroids properly, so then it's progress to subepithelial fibrosis. Obviously, as you know, these fibrotic changes are irreversible. So you cannot change even with the later, as our previous presentation showed, this arthritis, yes, very clearly, once the damage happens, once the fibrosis has established, so it's very difficult damage, whatever the available sophisticated biologics we use. So that's important. And the airway smooth muscle hypertrophy, global still hyperplasia, all these pathological changes that we have learned as third-year medical students can really happen in the airway epithelium if we do not address this properly, especially during childhood. And various genetic factors involved, various genes has been identified in different areas which involving, and other important thing is expression of these genes, how the environment affect the expressions of the genetics as well as this epigenetics mechanisms. Now some studies are going on to identify some MRI markers to identify which epigenetics factors involved in the expressions of these genetics and the finally leading to development of these chronic changes or permanent changes. One of the important article recently published, so they have identified this pre-adolescence DNA methylations. Pre-adolescence, during early childhood, the progression in childhood and adolescence is associated with lung function trajectories from pre-adolescence to adulthood. So they have identified some important change in the DNA methylations that identify as pre-adolescence, and that these changes might lead into the expressions of some genes and finally lead into the development of these chronic diseases, chronic lung diseases. And some metabolic signatures, like for example, identification of different types of mRNA, different mRNA expressions of these mRNA types. They have identified this micro mRNA 143 feet, little complex area, but now the world is moving to identify these molecular levels and genetic levels, the markers which predispose into these changes, and they have identified, that's one important, the message today's one, adolescents, children, now still we don't get any publication about the children, but adolescents, these changes would change the trajectories of the normal lung development. At early life visas, trajectories associated with distinct asthma transcriptomes. This is the thing. So the transcription of the genes might change with these diseases and uncontrolled symptoms. So these factors later in life. So early life longitudinal Wheezing trajectories are associated with specific asthma transcriptomes later in life. So like that, it's a little complex things. So obviously we're not going to into details, but just to show, yes, it's an important area, and the studies are going on to analyze this molecular level, but that indicates importance of identifying and treating these conditions as childhood. So then, what can we do? Obviously, the asthma management is very important, but it's not a time to discuss the management of asthma in children. But important is identify the patients who are on abnormal lung functions growth trajectories as early as possible. Importantly, what interventions and when to intervene. So it's important identify these patients and do assessment regularly. Where children with asthma, especially those with more severe disease, should undergo spirometry at least annually to assess the risk of future early onset chronic obstructive diseases. As Professor Christine mentioned, even developed countries, this spirometry being used less frequently. When our setup, it's a condition is worse, but this is the time to identify these patients, use the spirometry more fruitfully to catch these patients, and especially to prevent the development of these chronic long-term diseases. So optimizing management is the key in at least some subset of people who are prone to develop, the susceptible, the more potential to develop COPD. Possibly we would be able to prevent, at least to reduce the burden of development of these diseases. So as Dr. Prasanjali shown this, it's a complex process. The inflammatory cascade in asthma, as you know, various inflammatory markers, now the biologics are there to directly target, directly hit or directly obstruct this inflammatory process. Various endotypes are going on. Yeah, changing the, how do we manage, by the way, arthritis? So arthritis is just painful red joints, and this is the most popular method of managing arthritis in Sri Lanka. So you can see, so every type of arthritis, this teller is working. Can we manage arthritis like this? Whether our rheumatologists manage arthritis like this? Never. As you know, they use biologics, they identify what is the exact type of arthritis and then directly manage the different types of arthritis, obviously not the management of arthritis like this. But unfortunately, asthma, also we are managing almost similar thing. We are just applying bronchodilators and some steroids over the airway epithelium for the longer durations, but fortunately it works for majority of people. That's the important thing. Yes, now it's a time to change, as Prasanjali mentions. The management of arthritis, they have changed. It's from one size fit model to we have to precisely medicine. And asthma management is also like that. It's shifting from one size fit to a precision medicine approach. That's important to identify these underlying endotypes, whether it's a T2 mediated one, less predominant or low predominant. But fortunately, still we can manage majority of these patients, especially children, with our usual routine way of using our inhalers correctly and properly. Because there are different types of phenotypes. You can see the management, the majority are in this the green zones. Okay, so simply we can manage with them with the proper inhalers, use of proper inhalers. Small, fortunately small proportions which need biologics and sophisticated treatments, still a dream in our country for respiratory diseases, but still the simple measures, that's one of the important take-home message, we can manage these patients majority, significant proportion of yes. But other group is the most important group to prevent the chronic disease, especially as I shown earlier, the study shows more severe disease, the more prevalence or more chance of developing the long-term diseases like COPD. Yes, so this group, yes, we can target this group. That's one of the important, because the proportion is very high in our setups. We have only, unfortunately, at least in children, very small proportions of children now who are having severe uncontrolled disease which need biologics, but majority we can manage with this, optimal manage with this correct diagnosis, because children especially there are very many asthma mimickers, sometimes some conditions like airway malacia, cystic fibrosis, some other conditions. The initial presentations exactly would be similar as asthma. Sometimes even they respond to bronchodilators and steroids, but obviously ignore the management and they will persist in as asthma. So we have to identify these people who's having the different other diseases presenting as asthma. So diagnosis is important, the identification of the asthma mimics are important, and the control-based assessment, that we follow this gene approach, this control-based and the stepwise approach, and to control symptoms and to prevent the exacerbations. An important thing is this. So it's not only the our part, it's a combination, use of shared decision making, which is sometimes lacking in our setup. Various factors are there, as you know. Sometimes in busy clinics in our hospital setups, it's very difficult to get their views, their choices, and their problems. So, but still, the optimum management, the patient's views are also important, and the use of proper techniques. So what is the best approach for use children, the inhaler method? So you can see the lung depositions, the proportions of lung deposition. This bar, this maroon color indicate the pharyngeal deposition, the blue color indicate the lung depositions. So what do we want is to reduce the pharyngeal depositions and maximize the lung depositions. So with the MDI alone, you can see significant proportion of these medicines retain in the pharynx, which give rise to local or even systemic side effects. And with the use of MDI with the spacer, proper use, you can see we can maximize the lung depositions, minimize the pharyngeal deposition, and with the use of the DPI alone, you can see again the significant proportions of particles retain in the pharynx. For children, it's always use of MDI with the valve holding chamber or spacer, and there are many studies they have proven with using this technetium-99 label particles the importance of using a spacer. With the spacer, you can see these the particles that retain or the going to the stomach or the systemic circulations can be significantly reduced with the use of a spacer. So always this is not, still we see this. Sometimes even parents ask, then Dr. Baba, lokoi me vidira paachina, but it's completely wrong. Always use a spacer properly. For small children, we can use a face mask, and when they are older, we can use with the mouthpiece. And obviously the inhaler technique. So it's just to stress the import of inhaler techniques. It's not the time to discuss the inhaler technique, but our setup, these are true our pictures. So they used various methods. Sometimes these parents, they invent various methods. They use, sometimes they just attribute to me, Baba, but its parental response is our response to identify these patients, whether they are doing it properly or not. So it's not a problem in our setups. Worldwide, improper inhaler techniques is problem. So it's had to use proper techniques, whether it's a multiple breath technique or the single breath and hold techniques. So always important education, educate them properly. And our setup, so myths. lot of myths regarding the use of inhaler, whether it's addictive to inhalers, whether the patient depend on it, and the way the inhalers become weak, so lung make weak. But so lot of educations, identifications, the importance of this persistent inflammatory response. So we have to educate them about this persistent inflammatory. That's important. But still, sometimes after explaining all these things, still sometimes they might ask, Doctor, me inhalers නැතුව manage කරගන්න බැරිද බබා? So it's always there. So we have to address it, and then the inhaler technique, we have to demonstrate it properly, and obviously check the adhesion. So whether they are adherent to our management, that's one of the important things. Whatever the medicines we prescribe, whatever the sophisticated, the high dose, if they don't use it properly, obviously, yes, always assess adherence. There are various methods to assess. Now, there are some electronic methods are there, which is not used in our setup yet. So these are important. And finally, uncontrolled asthma, the use of biologics. So already Dr. Prasanji did a very good outline about the use of these biologics, and children also. There are a few biologics approved. Unfortunately, it's not available in our setup yet. And about the trajectories. This is one of the important recent publications. How the trajectories of these lung function, severe asthma, change with the use of these biologics. So that's one of the important things. It's anyway the adult study over 18 years. The use of biologics to severe asthma, they have identified, especially with this dupilumab. You saw the IL-13, what's the importance of use the IL-13 and blocking IL-13. So you can see the trajectories has gone up, right? So significant change. So it's very important to identify this properly and proper management. But till that, we have to stuck with our routine management. Future, whether we can prevent asthma, the primary prevention, so the secondary preventions cure. Still, we don't have, these are not realistic targets at the moment, but till that, we have to stick into our basics. So accumulating evidence for childhood onset adult diseases, even COPD, at least in some proportions, is a pediatric disease. Onset is at the childhood. So pulmonary functions gradually increase with age and then gradually decrease with the age. So it's impaired rise in an accelerated decline associated with the COPD. So uncontrolled asthma, one of the important risk factors for these diseases. So proper management of asthma probably prevent at least some proportions of these chronic lung diseases. Thank you.
Thank you for that enlightening session, sir. I would like to call upon Dr. Dilesha Vadasinghe, Senior Lecturer and Consultant Chest Physician, to deliver the token of appreciation to our respected speaker, Dr. Chanadi Silva, Consultant Pediatric Pulmonologist. Thank you, sir. Coming up next is the session on practical asthma management, getting the basics right. I kindly invite Dr. Sasanka Vijayawardena, Consultant Respiratory Physician, District General Hospital, Ambilipitia, to give us a practical overview of asthma management and the importance of adhering to the basics.
Good afternoon, ladies and gentlemen. First of all, I would like to thank Sri Lanka College of Pulmonologists for giving me this opportunity to talk to you today about practical asthma management, getting the basics right. And I would also like to thank excellent lineup of our renowned speakers who laid me a good foundation to talk to you on this topic. And also I would like to minimize repetition as much as possible and to be precise and to deliver only the key messages that would be applicable for our day-to-day clinical practice. So within next 25 minutes or so, would be going through identifying the gaps in the routine clinical practice, reinforce the non-negotiable basics, and most importantly, to translate these guidelines into bedside behavior. So the core problem that we all of us know is that bronchial asthma is still underdiagnosed and undertreated. It is associated with significant number of preventable morbidity and mortality. What we see is that most poor outcomes in bronchial asthma, or what we call as difficult to treat asthma, are due to either one of these factors or combination of these, like wrong diagnosis, no ICS in the treatment regimes, poor inhaler technique, poor compliance, morbidity, no follow-up some of the time. So usually the problem lies not being having problem lies with not being having advanced therapies, but not being getting stick to the basics. So I would be going through some basic rules within next slide. So the basic rule number 1 is getting the diagnosis right. So to confirm the diagnosis, almost the first is the good clinical history. So we need to elicit from our history the variable respiratory symptoms. That means wheezing, SOB, cough, chest tightness that would vary over time and intensity. I would highlight the varying over time and intensity. And to objectively confirm it with the test that would show variable expiratory airflow limitation. So what do we have as the test? We have spirometry with bronchodilator reversibility. We can do peak expiratory flow rates, and in specialized settings, bronchial challenge test as well. But what we should not be doing is actually labeling any wheeze or any cough as asthma, basically not to underdiagnose or overdiagnose, and not to underestimate acute respiratory events that most of the people would be coming to a general practitioner or the OPD, to label them only as having acute bronchitis or like acute upper respiratory tract and let them behind with some treatment, rather to look into the detailed history and see whether we can elicit these variable symptoms over time and intensity. And if possible, not to start inhalers without confirmation, because as you heard earlier from our renowned speakers, once we start on anti-inflammatory agents, sometimes we might not be eliciting the proper symptoms that we would see. So use spirometry with bronchodilator reversibility whenever possible. Most of the peripheral hospitals, district general hospitals now also having access to spirometry, but there again, to emphasize on few things, that spirometry is something effort dependent, and so to use proper techniques when doing spirometry and to interpret spirometry with caution. But of course, if not, spirometry is not available, not to wait. If your clinical signs towards asthma, treat them with inhalers, including inhaled corticosteroids, and reassess the response in 4 to 6 weeks' time. However, always reconsider the diagnosis if you see a poor response or any atypical features or red flags. Basic rule 2, the use of biomarker toolkit. So we heard about the biomarkers in detail. So at the outset also, if we can phenotype our patients, that would guide us later in our management as well. So if facilities available, use the biomarker toolkit, that is fractional excretion of nitric oxide. In Sri Lanka, we do have available in the tertiary care hospitals, and blood eosinophil counts. There again, in our context, to interpret these blood tests as well as the pheno with caution, because there are many other clinical conditions that would give rise to high eosinophil counts, high phenos, so interpret with caution. So I'm quoting Gina here to summarize the criteria for diagnosis of bronchial asthma, basically clinical symptoms that is varying over time and intensity, to confirm it with objective testing with spirometry with bronchodilator reversibility. The criteria would be looking at FEV1 and FEC, where there is 12% plus 200 ml rise as the bronchodilator reversibility criteria. But if you don't have spirometry facilities, but at least do have facilities for PEF, look at the variability at PEF. More than 10% variability in PEF in adults would give us an idea about the variable airflow limitation. And in specialized settings, we could use methicillin challenge test. Unfortunately, right now at the government sector, we don't have these facilities. And of course, when facilities available, use the biomarkers at the outset so that we are sure that we are dealing with confirmed diagnosis of bronchial asthma. That is basic rule 1, 2, 3. So basic rule 3, ICS is fundamental in treatment. We had an excellent talk from Dr. Naranjan Dissanayake outlining how the ICS would play in asthma. But we do see the common problem that many SABA only prescriptions, and patients believe that blue inhaler is the cure because that will quickly relieve their symptoms. But looking at the evidence since 2019, no patient should be on SABA alone. This is a paradigm shift in asthma management that is there since 2019. So our approach should be stepwise track 1 and track 2 approach with use of anti-inflammatory treatment, because in simple, reliever would treat the symptoms, but ICS would treat the disease. So no SABA alone, that is the key message. And why not SABA alone? Many factors which our speakers highlighted earlier, so I wouldn't be going through in detail in this slide. And this is the track 1 and track 2 that you all are familiar with. So the preferred would be using ICS formoterol combination, where again we had these talks earlier, and track 2 would be where there is no availability of ICS formoterol. So the difference would be we would be using LABA ICS combination. So as we moved this year, we do have government hospitals facilitated with ICS formoterol combination, but with a limited stock. So some patients we could manage on the preferred track 1, but most of our patients are on track 2 pathway, alternative pathway. So the important message is to place them correctly on their step and manage them accordingly than using SABA alone. So basic rule number 4, asthma treatment is not just identifying the disease, identifying that they would need an anti-inflammatory control therapy, and then forgetting there. It should be a personalized asthma management. So it is not set and forget, and it is not just medication. We always need to involve our patient in this cycle where we need to regularly assess, regularly adjust, and regularly review their treatment and management. Basic rule 5 about the inhaler device and technique. We short while ago heard from Dr. Channa as well about the many myths around inhalers, poor inhaler techniques and all, but the uncomfortable truth that we have to accept is that majority of clinicians, we don't check the technique. Time is a limiting factor. We can't always blame them as well, but time is a limiting factor, and lack of patient education and myths also contributing. So the common errors that we do see: no breath coordination, inadequate inspiratory effort, and no spacer usage. So the practical rule, I would say, never escalate treatment before checking the technique. Assessment of technique of the patient, your patient, is essential in each and every visit. So approach to decide on the inhaler device and way of delivery should be a shared decision making, where we have to get involved the patient also to look at the patient profile, look at their age. Sometimes they might be just having shaky hands, that we have given a MDI or a DPI where the coordination is not that good. So to involve the patient and go for a shared decision making with regard to the choice of the inhaler and inhaler device, and to have a look on the technique and inhaler to be patient as well as environment friendly. Approach in this approach, what else that we need is actually we will need skill training for effective use of inhaler device. We are using pictograms, we are using videos, but the best would be physical demonstration. If the clinician or a trained healthcare provider can give a physical demonstration to the patient would be able to identify where the gaps are there in their inhaler technique, and which would be very fruitful in overcoming the barriers there. And would say, after doing those physical demonstration as all, use a standard checklist to assess whether the technique is correct, rather than just at the outset saying your technique is poor or your technique is correct. Use a standard checklist, because it will keep the uniformity in inhaler technique assessment, which I would show you a checklist which we can use with day-to-day practice. And of course, capacity building. With regard to this approach, nurses, pharmacists, and even a trained healthcare supportive staff could check on an inhaler technique while they've been just waiting for the doctor in the routine day-to-day asthma clinic. So I'm quoting this from UK Inhaler Group, that is a 7-step inhaler technique assessment checklist. I think we should be using our own translations in Sinhala, Tamil, and English medium to keep this uniformity, so that it would be a checklist that would be assessing in each and every visit. And it wouldn't be the doctor's task itself, because any trained healthcare provider would be able to check on this, and it would give a self-reflection to the patient himself as well, because they know where they went wrong in the first attempt, so that they would be correcting themselves, and it would be kind of a peer education as well. Basic rule 6, adherence to inhaled treatment. So the reality is non-adherence is common and actually often unrecognized. It could be because of the misconceptions about the inhalers, about fear of steroids. It could be complex regimes that we have prescribed to the patient, cost and access issues as well. Our approach should be, we need to acknowledge, we need to normalize non-adherence. We should be non-judgmental and having a good communication with the patient to actually explore where and why the adherence is becoming poor. So to identify the barriers and simplify the regimes if possible. For example, a busy worker who wouldn't be able to take their morning dose most of the time if they are missing a morning dose of inhaler, whether this is possible to go for 2 doses at night time rather than we been pressing on and going for escalation of our treatment, which is wrong actually. So escalation of therapy without assessing adherence leads to actually pseudo-treatment resistance. Basic rule 7, assess asthma control. I would highlight assess asthma control systematically. Most of the time we would ask from the patient how you are doing. Their answer would be, I'm doing all right. It would be sometimes to please themselves, sometimes maybe the actual truth, but sometimes it may be just to please us or please the patient. And of course, we know some of our patients, they are not good historians that they would tell us each and every symptom what is bothering them. So our approach should be, we need to assess the asthma control systematically with regard to 2 domains. First domain, assess the symptom control. Second domain, assess the risk of adverse outcome and assess the risk of future exacerbations. So we do have assessment tools. We have categorical and numerical assessment tools to systematically assess the asthma control. A categorical thing would be something like APGA, which I haven't discussed here, but things like asthma controls test, asthma control questionnaire, which give us a detailed account about the patient's current asthma control. And if the time is a limiting factor again, at least to use this simple 4-question method to assess their control systematically, looking at whether they have daytime symptoms, nighttime weakness, how about the reliever use, how about the activity limitation, and systematically label them as having whether their asthma is under control or not, rather than at the outset saying, look, this patient is having good asthma control. Basic rule number 8, looking at non-pharmacological strategies as well. Cessation of smoking, environmental tobacco smoking exposure, vaping, all these would matter in asthma control. Regular physical activity, engage them in pulmonary rehabilitation, avoidance of occupational and domestic exposures, avoidance of medication that may worsen asthma, healthy diet, breathing exercises, and dealing with emotional stress, all would be contributing for a good asthma control. Basic rule number 9, avoidance of triggers and multimorbidity and looking at treatable traits. We heard this multimorbidity contributing a lot to asthma control, and also it will be impairing quality of life, and it will be increasing in healthcare utilization, and also will adversely affect utilization of our medication and all. So to look at this multimorbidity in all patients, whether there is evidence of rhinosinusitis, obesity phenotype, anxiety, depression, it could be vocal cord dysfunction, inducible laryngeal obstruction, reflux, OSA, all these treatable traits, whether our patient is having or not. So to have a proper assessment on multimorbidity and to have a look on treatment traits should be a part of our comprehensive personalized asthma care. So all this actually summing up around this slide, our approach to asthma management as of GINA guideline is actually to give the best possible long-term asthma outcome for our patient. Basic rule number 2, exacerbations, they are predictable in bronchial asthma. So when we treat this chronic disease in the community, also to prevent exacerbation, that would be a that would create a major impact on the patient's life. So most of the time, the exacerbations, they would not come out of nowhere. we can predict the exacerbation of our patient. It is usually associated with poor control of the disease. Sometimes it could be SABA overuse, not having ICS in their treatment regimes, and of course, if they are dealing with low lung function. So approach to identify this as exacerbation, approach should be at the level of primary care, where they would have frequent encounters with their general practitioners, and of course to self-educate and empower them with the knowledge how to identify exacerbation. That would give us a better prediction to identify exacerbation of a patient and to reinforce our acute management basics. So I would highlight this personalized asthma action plan, what we call as a traffic light system. So to have this included in our patient management, of course with all the translations as well, when our patient feeling better, when I'm feeling unwell, and when I'm having an asthma attack, because that would give a self-information and a self-education material to the patient to act correctly. From them, we would be able to prevent an exacerbation being happening. Basic rule number 10, to have a good acute care and a discharge planning. Common thing that we see day-to-day practice is that asthma patients getting admitted, nebulized, improving, and getting discharged from the hospital. But we should include ICS in their treatment and to see whether they have correctly keep them on the correct step of management, whether the techniques checked, whether the techniques corrected, whether we have identified the triggers, whether we have addressed the multimorbidity, and to have a proper follow-up arrangement. In West, we use early supported discharge. I think it's time that we've been having access to these primary care units now to have some integrated approach from our tertiary to secondary care to the primary care, so that there would be a good flow of patient, a good flow of management of the patient from the tertiary to the primary when we are discharging them rather than just discharging them blindly. And the important point that I wanted to highlight here is that exacerbation is a clinical opportunity to correct the long-term management of our patient. Basic rule number 11 would be about the stepwise management. We discussed about escalating the therapy, but our correct approach should be to step up if uncontrolled and step down when stable. Use the asthma control test, asthma control questionnaires, use the simple questions, and to identify whether our patient is getting controlled on the correct step of management. If the symptoms are under control within 2 to 3 months, then to have this step-down approach, because our goal should be to achieve the control with minimum effective medication. And basic rule number 12, the before you escalate checklist. At each and every step before you escalate treatment, always ask whether I'm dealing with the correct diagnosis, whether the inhaler technique's correct, are we on correct strength of medication, is adherence adequate, have we identified any triggers? Have we addressed these multimorbidity and everything? So if not, we should go back and we should fix our basics first, because that will prevent we being over-treating patient, and that will prevent and avoid misclassifying them as difficult to treat asthma or severe asthma, and it will reduce unnecessary healthcare cost, and of course it would increase overall outcome of our patient as well as the healthcare system. So let me conclude my talk with these 2 key messages. Excellence in asthma care lies not in complexity but in consistent execution of fundamental principles. And only after fundamentals of asthma care are consistently optimized, true difficult to treat, true severe asthma become clearly identifiable, requiring advanced phenotyping, specialized treatment, and consideration of biologic therapies. Thank you very much for your valuable time.
Thank you for sharing your expertise with us today, madam. I would like to call upon Dr. Amita Fernando, Senior Consultant Chest Physician, NHSL Colombo, to deliver the token of appreciation to our respected speaker, Dr. Sasanka Vijayawardana, Consultant Chest Physician. we would like to now open the floor to questions from the audience. If you have a query, please raise your hand and the microphone will be brought to you. Our respected speakers, Dr. Sasanka Vijayawardena and Dr. Chana De Silva will remain in the podium and will answer the questions.
With regard to surgery, there are perioperative patients. I know you discussed a lot about, your strategies for asthma patients. So if the patients are admitted for, say, elective surgeries on an asthma patient, do you have sort of a perioperative management strategy? Because otherwise, if the asthma gets worse, we may have to postpone. There is a cost involved, and patient's operation get postponed. So what advice you could give, or what strategy you can adopt for that, please?
Yeah, thank you for that question, sir. So the first thing in perioperative management would be to risk stratify our patient based on the patient profile. So it should be at the outset based on their symptoms, based on their risk of exacerbations over the last year or so, and looking at the lung function, and based on that to give a risk category to the patient. So, for example, if the patient is on step 1, step 2 management with no exacerbations and considerably good lung function, risk of them getting a perioperative or a postoperative complication would be less. So that particular patient would be going in the same regular treatment that patient is undergoing. But if we are seeing that more symptoms, more exacerbations, and we are calculating perioperative risk based on the lung function, like the postoperative predictive values and on based on the lung function, so that if that is giving us an alarming thing, then our approach should be to optimize them as much as we can. So the optimization would be giving them the correct inhalers with the correct adherence and all, and to involve the breathing exercises, pulmonary rehabilitation, good nutrition plan, and all that would matter to have a good outcome after the surgery also.
Thank you. So there is no place for sort of universal IV steroids perioperatively, no?
I would say no, sir.
I've seen certain, anesthetists, they are very keen to give some steroids, thinking there will be exacerbation prophylactically. There's no such place.
No such place. And also, if they are on correct combination of LABA and ICS, there wouldn't be added benefit of just them nebulizing prior to the procedure as well, because they are on correct control of treatment.
Thank you to all speakers for excellent presentations. Is Prasanjani still online? Or is Dr. Prasanjani online?
Yes, sir. Yes.
Thank you again for a very nice talk. My question is to you. Do you consider, when you in the Th2 low asthma, would you consider trial of macrolides before you move on to teplizumab and biologics like that? Is that your practice in your center?
Yes, sir. We do T2 low asthma. We do treat with azithromycin. And so the tocilizumab, it's like a bit of a questionable. It's not always yes for tazi when we have a T2 low asthma. So I think recently, actually, I went for a lecture actually by Professor Ian Parward, who is one of the pioneer in biologics. And he also explained he's still not very sure about place in TASI for in type 2 low asthma. But I think case by case, sometimes they might consider that, but mainly it's azithromycin and then managing this other associated comorbidities.
Thank you, Prasanjani. Just to add on to what Sasanka said, that and there are experts in cardiopulmonary exercise testing, and you mentioned prehab. So cardiopulmonary exercise testing, I don't know what Dilesha may like to comment on it, will have a role in assessing patients that Dr. Handagala mentioned.
Yes, as Sasanka told very clearly that we do risk stratification. So if your VO2 max is quite low, less than 14, we know that the perioperative risks would be higher. So what we can do is we can arrange pre-rehab. We can see whether their airway clearance needs to be addressed. So all those things can be done pre-operatively to optimize them. Sometimes if the patient is having some mild symptoms, obviously we can use some nebulizations perioperatively as well, and that would help if the patient is not very, very controlled, but we anticipate that the patient gets quite frequent exacerbations. So doing a cardiopulmonary exercise test, now what we usually do is we do the normal spirometry. If the normal spirometry, the lung volumes are low, then we go ahead with DLCO, the full lung function assessment. And if that is still again low, then we recommend as cardiopulmonary exercise testing to make sure that the patient's risk is quite satisfactory for the surgeons and the anesthetist to go ahead with. Or otherwise, we can do some prehab programs to optimize their lung conditions.
Yeah, I know you have your arms ready, but the patient need to be referred, no?
Yes.
Most of the time what happened is the anesthetists manage themselves. Only if they refer to you, then the things will work on. So we need to make awareness among the anesthetists and the critical care people, but there's a proper way to do this. Otherwise, they themselves manage, and when they fall into trouble only, they will enroll you post-op.
Yeah, just to add, I think what Dilesh said, now patients who are waiting for CABG, and especially after in the recent past, if the patient has an ischemic event, so putting the patient on spirometry, TLC or even CPET, it can carry a high risk of ischemic event, and we have to be a little mindful putting those patients in those excessive pulmonary function test before, even though the patient is prepared for a elective surgery.
Online participants, we also entertained some questions from our online participants. In the absence of any questions, we move to the next item on our agenda. To close today's program, we have an expert panel discussion led by Dr. Amita Fernandu, Senior Consultant Chest Physician, National Hospital of Sri Lanka, Colombo, and Dr. Dilesha Vadasinghe, Senior Lecturer and Specialist in Chest Medicine, Department of Physiology, Faculty of Medicine, University of Kelaniya, where we will explore difficult and complex asthma cases and the latest best practices. I call upon the panelists to be on the stage to conduct this session. Also, this session will be moderated by Dr. Chandana Dahanayaka, Consultant Chest Physician, District General Hospital, Hambantota. Over to you, sir.
Right. Thank you, Nishant. And I welcome our expert panelist, Dr. Amita Fernandu and Dr. Dilesha Vadasinghe. So we'll move to the case. So there will be two cases, and those cases will be presented by our senior registrars. So we'll start the first case. Over to you.
Thank you. So this is our first case presentation. So Mrs. X, we call her Mrs. X, and a 61-year-old female, a medical professional, presented with an 8-month history of recurrent episodes of dry cough, wheezing, and shortness of breath, usually triggered by upper respiratory tract infection without diurnal variation. During these episodes, she frequently used nebulization and a salbutamol inhaler, which provided only temporary relief, with symptoms recurring repeatedly. She has never been on a regular maintenance inhaler therapy. Over the last month, her shortness of breath and wheezing on exertion have progressively worsened, with MMRC increasing from grade 2 to grade 3. The initial episode of wheeze was after a change of residence and also an exposure to dust and cleaning in a storage area. And interestingly, there is no prior diagnosed asthma history, but there was a history suggestive of atopic tendency. She had an allergy for hair dye a few years back. And no past history of or contact history of tuberculosis, no history of exposure to poultry products, birds, and she is a non-smoker. On respiratory system examination, she is not dyspneic at rest. Oxygen saturation was 99% on room air and vesicular breathing with equal air entry and widespread bilateral bronchi. Systemic examination were unremarkable and there was no features suggestive of heart failure and no connective tissue disorder features. Her basic investigations, a full blood count revealed that WBC count was 8.97 and there was a marked eosinophilia with absolute count of 5.1 and the relative count of 42%. And hemoglobins and the platelet were within normal range. And the blood picture, moderate eosinophilia with normal morphology and normal WBC and the RBC. And ESR was mildly elevated with 15. And despite of antihelminthics and the DEC, the hypereosinophilia was persisted. This is her chest X-ray. And this is the lung function test, and FeNO, it was 15. And this is the image of the lung function test. So it's time to question.
Yeah. So what do you think of the lung functions and the body works? Do you have any comments?
Yeah, now this from the history, this is a 61-year-old patient who comes with adult onset recurrent cough, wheezing symptoms, never been on inhalers, not diagnosed asthma. So the first step we will have to look is to see whether this patient is asthma or is it not asthma. Is it asthma plus something else? Is it having asthma comorbidities, or this is an asthma mimic? So looking at the lung functions, I'm sorry that I can't see the slides there, so I'm just looking it on the phone here. And one thing I wanted to emphasize is now when we are interpreting lung functions, we go from the percentage predicted to the lower limit and the upper limit of normal values. So when all of our lung function reports do carry those values, and it's quite easy rather than remembering numbers as well. So it was always we are using 80% previously, but now it is a bit different and we don't use 80% anymore. Right. So, but because we have the 80% predicted values, we'll go by them. So the FEV1 we can see is reduced. The FEC is also reduced, but looking at the FEV1 to FEC ratio, it's preserved. It's more than 70%. So this does not typically suggest an airway obstruction just as it is, but it is, we'll call it preserved ratio impaired spirometry pattern here. Now when we look at the residual volume, seems it is a bit increased, and the total lung capacity, do you know the percentage predicted or the lower limit of normal?
Yeah, 77%.
Yeah, so the total lung capacity is reduced a bit. So that pattern, what we saw, the preserved ratio, and there is somewhat restriction in this lung function as well. Looking at the DLCO value, we can see that there is a mild to moderate reduction in the DLCO value, but when we look at the KCO value, which is correction for the volumes, so it is normal. So this would suggest not a definite parenchymal problem at the alveolar capillary membrane, but it will suggest some abnormality, which is maybe extrathoracic thing. Do we know her BMI as well?
It's within normal range.
Yeah. Now looking, the interesting thing about the residual volume to TLC ratio, if this is more than 0.4, we take it as air trapping. So in this lung function, I would tell it is not typical obstructive pattern. It is a preserved ratio spirometry abnormality, which shows some peripheral air trapping, which would suggest small airway involvement and some degree of restriction as well. Now looking at the FeNO here, now we know in asthmatic patients, we expect to see and with that knowing that there was a very high eosinophil count, we expect to have a high FeNO, but it is not the same case because we know the FeNO is usually, as Prasanjani mentioned and the previous speakers mentioned, it is due to IL-13 inflammation mainly. So probably this patient would have had IL-5 driven inflammation, eosinophilic inflammation, or the patient must have received some steroid treatment just prior to these testings. So both possibilities can happen. So that is what I would suggest from these lung functions. And a nice thing what we would see in the spirometry here, the first curve, you can see that there is the inspiratory instability. The inspiratory curve is the one which is on the bottom. So it's not a smooth curve. There is a small kinking in it. Now, usually, if this kinking is very persistent, we see it in ILO, the inducible laryngeal obstructive patients, we see this small kink here. Now, looking at the graph below, it is the resistance, but it's not very clear, but we can see if we enlarge it quite a lot, you can see that the expiratory loop is slightly widened, which would suggest that there is some degree of small airway, increased airway resistance as well. So that is my take on the lung function test. So there is small airway obstruction, so small airway involvement, and a bronchodilator reversibility test is not available for us to tell whether there is reversible airway obstruction or not. And there is possible some degree of restriction as well, and I would suspect into ILO as well, the inducible laryngeal obstruction, at least contributing to some extent in this patient's symptoms.
Just a clarification from Tilesha. In these instances where it's probably like a precision mapping what you are saying,
Yes.
paired spirometry, would you still consider doing a bronchodilator reversibility, which hasn't been done? And would you, what do you think IOM may have a role, impulse oscillometry in these patients?
Definitely, sir. So impulse oscillometry would complement our findings, because I'm not quite sure whether this patient has received some steroids time to time, or whether the patient has been on steroid just before the testing happening, which shows that the preserved ratio would be due to that. But there's clear evidence of small airway involvement and air trapping in this patient. So impulse oscillometry would give us an early pattern of this airway inflammation and small airway obstruction, and also a reversibility test I would definitely do, because that will tell us, because of this air trapping, and whether there is a reversible component on it.
Okay, thank you, madam. Then because of the inspiratory spikes in the lung function test, we also proceeded with the vocal cord dysfunction, which revealed that there was a high score with total of 28%. As her symptom disproportionate to the lung function test and the high VCD score, we proceeded with the CPET test.
Any comment?
Yeah. Now, looking at this, I don't have the numbers for the CPET, but just the graphs, what we see, which is very important, the one right at the bottom, you can see that in the yellow is your breathing frequency and the brown line is your tidal volume. So in this patient, you see the patient compensates, the respiratory system compensate by increasing the respiratory rate rather than increasing the tidal volume of this patient. So this would suggest the vocal cord dysfunction. Patient feels that the patient cannot breathe. So the patient takes rapid shallow breaths rather than increasing their respiratory tidal volume. So this would suggest that as well. And there can be some dysfunctional breathing in addition to this. And for that, we need to look at the breathing patterns of this patient, which obviously would have shown some irregularity in the breathing as well. So this again, looking at this, just the graphs, seems like the patient is, the VO2 is going to the correct level. So the patient is having a good VO2, but still the patient is having poor compensation with respiratory rate increase rather than tidal volume. So dysfunctional breathing and vocal cord dysfunction would be supportive by the cardiopulmonary exercise test as well.
Okay. So for the evaluation of high eosinophilia, so we did serum IgE level with we showed that more than 2000 And we also did the serum filarial antibody test, which showed negative. And the toxoplasma screening, both IgG and the IgM are non-reactive. And also, because of the high IgE and the high eosinophilia, we did also the vascularity screening. And ANA 1 in 160, which was cause speckle pattern, positive reaction. And the C ANCA, P ANCA was negative, and the ACE level marginally elevated with 64. And the fungal screening, which showed negative results with serum Aspergillus IgG negative, and the serum Aspergillus fumigated IgE also negative, and the marginal elevations of serum Aspergillus galactomannan 0.72. So this is the HRCT chest of this patient.
Any inputs with regards to HRCT and the patterns?
Thank you, Chandra. Yes, we have. I've seen these films before, so I can come in. I would look for in the index of high IgE, but especially specific IgE negative. I would look for features of bronchopulmonary aspergillosis, airway-centered features, central bronchiectasis, and other features that we see in bronchiectasis, but we do not see any such features in these patients. What seems a little obvious is that there is some degree of air trapping, which we would have to, of course, look at expiratory films, and we do coronal reconstructions in CTD-ILD patients, and we also look at many projections to look whether they are air trapping. So I would say that we don't have any other features of like hypereosinophilic, chronic eosinophilic pneumonia, allergic bronchopulmonary aspergillosis. What we see is air trapping, little mosaic attenuation in the patients. So I would suggest that there is some airway, small airway disease, as Dr. Dilesha suggested with the spirometry.
More investigations. So
yes, given the history of this exposure, dust exposure, past history of atopy with hair dye allergy, eosinophilia, though FeNO was negative, and as Dr. Dilesha said, we have to see whether the patient was on steroids, Montelukast and things just prior to the FeNO testing, and negative Aspergillus serology for ABPA. I would still consider whether there was an element of fungal sensitization in this patient, and I would proceed to do a skin prick test, looking for especially indoor mold like penicillium and outdoor mold like Alternaria cladosporium.
Yes, sir. We proceeded with the skin prick test, and which was positive for house dust mite, storage mite, and the dog and the cat epithelium and the penicillium with positive results.
Yeah, so the patient has multiple allergies, and house dust mite and indoor mold penicillium is positive. Interesting feature is this house dust mite, cockroach, and mold have a carbohydrate exoskeleton which has what is this? Chitin and other proteases. So she has some degree of sensitization.
Yes. So with the positive skin prick test and the supportive serological markers, fungal sensitization of asthma was made, and she was started on combined inhaled corticosteroid maintenance dose along with antifungals, itraconazole, oral itraconazole, 200 milligram BD dose. And with this positive skin prick test for penicillium, also we emphasize environmental control measures which play a crucial role in managing fungal sensitization. As this is an indoor fungal allergen, penicillium, it's mainly found in the damp indoor environment and stored food and air-conditioned systems. So we emphasize that environmental exposure control. In contrast to Alternaria and the cladosporium are mainly outdoor fungal allergy. So with this combined approach, both the pharmacological treatment and the exposure control prevention, our patient showed remarkable improvement in both clinical symptoms and the serological markers. So move on to fourth question.
Text, do we have a place for biologics? And if so, what will be the choice?
Our first choice would be itraconazole. I think they were studied, and the FAST study, which was sometime back in 2009, I think Professor David Denning, who did the study, he was there at our sessions the year before, and he spoke about fungal sensitized asthma. If you are considering biologics, FeNO is negative, so dupilumab would be not there. But if there is mucus hypersecretion, mucus plugs, dupilumab may have a place. But since the dominant feature, as Prasanjani said, is eosinophilia, I would consider anti-eosinophil drug like benralizumab or mepolizumab, risarizumab. I would consider anti-eosinophil mab. Dilesha will be back.
Now, in this patient, the patient has not been on regular treatment, and we're not very sure whether this is pure asthma or not. So, before considering biologics, I would first make sure this is asthma, repeat the spirometry, repeat the impulse oscillometry, and make sure the patient is having asthma component, as well as very clearly said, we will exclude other eosinophilic pathologies in this patient before we really consider biologics. And one important thing is, as our lung functions and the patient's history was suggesting some degree of dysfunctional breathing and ILO, I would first do some speech therapy and to correct the ILO symptoms, as well as before we go on to biologics, because that is what we can do for our patients first, and proper inhaler technique, adherence to treatment, and then reassess our patient, because the GINA guideline says that 4 and 5 step patients would be recommended biologics. So we need to optimize all of that, reassess, and if the patient is again symptomatic, with our scores, we can use the ACT score on our patients, and then we can consider the biologics as surgery.
Okay, thank you so much.
Yeah, thank you, Disney. And with the interest of time, I think we'll move to the next case. Yes.
Good afternoon. For the second case, we have a 24-year-old female who was previously healthy with no prior history of bronchial asthma, allergic rhinitis, or atopy, who presented with low-grade fever, progressive wheezing, and shortness of breath and productive cough since June 2025. So, going to the beginning of the illness, she has been apparently well up until last June, when she presented with low-grade fever with malaise, loss of appetite without any significant weight loss, which was associated with productive cough and mucopurulent sputum, episodes of wheezing, and shortness of breath. There had been no diurnal variation or specific triggers identified for wheezing, and she had been managed as LRT, lower respiratory tract infections, as outpatient, but had not been started on regular inhalers. She also, on further inquiry, she claimed to have a significant bird exposure, where she admitted to having several sparrows' nests inside her house. There was no history of active or passive smoking. There were no occupational dust or chemical exposures. There were no features of connective tissue diseases, no skin rashes, or evidence of vasculitis, rhinosinusitis, or nasal polyps or epistaxis. She complained of having GORD symptoms. There were no features of heart failure. There were no past history or contact history of TB, no personal or family history of atopy, asthma, or allergic rhinitis, and no recent travel history. And then by December last year, she complained of having progressive worsening of her symptoms with wheezing and shortness of breath, and had developed expectoration of brownish tubular flakes of sputum. With that, she had presented to the local chest clinic. So in the local chest clinic, she was found to have bilateral bronchi at presentation, and basic investigations and chest x-ray had been done. In the basic investigation, her WBC count was found to be 22,000 with marked eosinophilia of 37%, with an absolute eosinophil count of 8,230. Hemoglobin platelets were normal, ESR was 40, and sputum AFB was negative. And this was the chest x-ray. It was slightly hyperinflated lungs with no obvious evidence of bronchiectasis. And on clinical grounds and due to the high eosinophilia, she was clinically suspected to have allergic bronchopulmonary aspergillosis and was planned to do a serum total IgE. Although a comprehensive parasitic workup had not been done at this point, she had been empirically treated with diethylcarbamazine 3-week course along with albendazole 400 milligram stat, along with a short course of oral prednisolone, and also had been started on fixed dose LABA ICS inhalers with SOS short-acting beta agonist. Then in February this year, she presents to NHSL with worsening wheezing and shortness of breath. And on admission, she was tachypnic, hypoxic on room air with saturation of 89, and was found to have bilateral diffuse bronchi, and had been initially managed as acute severe exacerbation of asthma with nebulization, supplemental oxygen, and oral corticosteroids. During this exacerbation, her basic investigations again revealed marked eosinophilia of absolute eosinophil count of again more than 8,000 with CRP with normal CRP and ESR. Renal and liver functions were normal. 2D echocardiogram revealed an ejection fraction of 60 with no evidence of restrictive cardiomyopathy. Sputum cultures and sputum AFBs were negative. These are the basic investigations. Along with that, she came with an HRCT chest, and this is the HRCT.
So please sit down. Yes. Please do consult. Yes, visit guys. That further down, there was with that's it. I'm pretty there. Sure.
Thoughts, sir, and the differentials that you can entertain?
Yes. Given the history, I would Nipuni mentioned about significant bird exposure. Eosinophilia is there, and given the history, with that in mind, what we see is patchy areas of consolidation, ground glass changes, non-segmental distribution, no particular lobar dominance. We see this area that has been paused. We see ground glass changes surrounded by areas of consolidation. The atoll sign that we see, which we associate mostly with organizing pneumonia, but not pathognomic. But we don't see the classic features of organizing pneumonia like arcades, subpleural distribution, bands and things. Another important feature that we see is we see hypo-attenuated areas in these films, though we should look at expiratory films to look for air trapping. So it looks there is no bronchiectasis or bronchial ball thickening, bronchial dilatation, which you would see in ABP or allergic bronchopulmonary aspergillosis. There is no features of bands, consolidations, non-segmental like in eosinophilic syndrome, chronic eosinophilic pneumonia. So I would say the dominant features are airspace shadowing, atoll signs suggesting a bronchovascular pattern of organizing pneumonia, and a dominant feature of air trapping where there is mosaicism. So our differential diagnosis at this stage would be hypersensitive pneumonitis. Again, it would be difficult to explain the the atolls can happen in hypersensitive pneumonitis, and you can see organizing pneumonia-like pattern. Hypereosinophilic syndrome can occur, but the dominant airway involvement with bronchiolitis and air trapping, unless you have eosinophilic bronchiolitis also, you cannot explain that. So ABPA, we don't see classic features of ABPA, which would be more bronchocentric, bronchiectasis, airway-centric disease. The other would be like EGPA or eosinophilic granulomatosis with polyangiitis or Churg-Strauch disease with a possible history of asthma, eosinophilia, organizing pneumonia pattern, and a dominant air trapping mosaic attenuation.
So moving on with the further investigations during this admission, we, with these differences in mind, we performed serology. The total serum total Ig turned out to be slightly high at 623. Aspergillus fumigatus IgE was negative. We did the PR3 and MPO ANCAs, which turned out to be negative. We also performed the ANA, which the nuclear pattern was positive 1 in 80 for dense fine speckle, which was interpreted as being positive in a fair amount of normal population. So because of the clinical pattern and the HRCT pattern, we treated her with IV methylprednisolone pulses of 250 milligrams daily for 3 days, followed by a tapering course of oral prednisolone with calcium, vitamin D, and ulcer prophylaxis. We also started her on a inhaler with formoterol budesonide 400 mics BD with 200 mics SOS in a MART approach. And with this treatment, she initially showed dramatic symptomatic improvement following the steroid therapy. We also performed a bronchoscopy and a bronchoalveolar lavage on her with the caveat of, however, the bronchoscopy was performed after the initiation of steroids. So the BAL differential count was a representative sample with 85% macrophages. However, it was negative for eosinophils. And BAL pyogenic and fungal cultures and BAL galactomenon was negative. Later, we got her down to do a lung function test, and we performed spirometry and pheno. So
yes, again, the physiology question goes to Dr. Didesha.
Come on.
What are your thoughts?
Yeah, so now in this case, we can see that the FEV1 and FVC are again reduced in this patient compared to the seen in the pre-bronchodilator. And now if you look at the FEV1 to FVC ratio, pre-bronchodilator, it is 70.35. So it falls roughly for airway obstructive type of spirometry pattern. And when you look at the total lung capacity, it is again mildly reduced, and the residual volume is increased, and the residual volume to TLC ratio is again more than 40%. So which would suggest there is small airway disease with airway trapping as well. So there is clear obstruction with air trapping in this patient. Now, to explain the reduced FVC, we can think whether this is due to air trapping causing this, and then the TLC reduction also would suggest, because now this patient we know in the history had some organizing pneumonia type of pattern in the HRCT, so that could also explain why the TLC is slightly reduced. Now, in here, what is very interesting is the post-bronchodilator value for the FEV1 is very, very markedly increased in this patient. So, the guideline says it's more than 200 milliliters plus 12% increase, the GINA guidelines. Now, when we take the GLI guideline for interpreting reversibility, it's a bit different, but still we go with the GINA because that is what GINA recommends to use the for asthma diagnosis reversibility. So there is a 63% change in your FEV1 with more than something close to a liter increase in your FEV1 values. So This is marked bronchodilator reversibility with obstructive type of airways disease and air trapping, and the FeNO here is quite high. So usually the FeNO less than 25 is normal, more than 50 is high. So this patient is having clearly eosinophilic or type 2 inflammation in their lungs according to the lung function tests. So I would like to do in this patient, maybe if because now you told me after the treatment there was a significant decrease in your eosinophil count and all of it, but still the patient was having symptoms. So maybe in this patient also, sir, the cardiopulmonary exercise test for the unexplained breathlessness would help to identify very minute things in this patient, such as a component of dysfunctional breathing with anxiety probably.
Get that in glory is.
Yeah, flow volume loop. Can just you, yeah. Now in this flow volume loop, when it is the difference from the other is in the blue one. In the blue one also there is the slight kink. Yeah. So the inspiratory stability, in this the phone, the blue one was looking something. Yeah. So that slight kink would suggest whether the patient is having a component of ILO, but then there is obviously a different pathology which is the major contributor for this patient's symptoms that may be contributory for this patient's symptoms as well. So ILO can be a contributory thing for this patient also. And it's quite common, though we don't diagnose.
It's so we have COVID.
We have bronchodilator response, and we got high eosinophils, also high moderately high IgE, and also with HRCT pattern. So including everything collectively, what do you think, sir?
Yes, looking at the flow, the spirometry values and significant bronchodilator reversibility, as you said, the GINA super responders, whom they say that had good bronchodilator reversibility, whom you may be able to step down at earlier. So both the radiological HRCT evidence and the evidence from the spirometry and air trapping lung function testing suggesting, and FeNO suggest a Th2 dominant inflammatory process, which may be driven by IL-5, IL-4, IL-13 cytokine profile. Again, considering the differential diagnosis we had in mind, though there was bird exposure and the HRCT is compatible with hypersensitive pneumonitis, this blood eosinophil, high IgE, FeNO positivity, in spite of being on oral steroids at the time, still the FeNO was over 100, is it? Was it?
Like it was close to 90.
Yeah, so still suggests a dominant Th2 type of inflammatory process. Again, in the other differential that we had is ABP, which now we can exclude because the serology was negative, especially the specific IG was negative. So the other was a chronic eosinophilic pneumonia. Again, a chronic eosinophilic pneumonia would not explain the spirometry, air trapping, bronchodilator reversibility, though FeNO and other inflammatory markers may be explained with the IG. Unless you have eosinophilic bronchiolitis or bronchitis along with your eosinophilic pneumonia, still that degree of 32% and reversibility, I don't think we would see. So considering the overall clinical picture, though ANCAs were initially negative, I would still consider EGPA or eosinophilic granulomatosis with polyangiitis in the asthmatic phase that we may have caught this patient early. And as Dr. Dilesha said, the flow volume kinking, we would have look like in any asthma, severe asthma MDT, look for these treatable traits as the Dr. Sasanka highlighting treatable traits, dysfunctional breathing and ILO before you escalate care.
So very true, sir. And the first step I would do here is again to check the patient's inhaler technique and correct if it is not, because this degree of reversibility, whether the patient has good compliance, and the inhaler technique as the first encountering doctor, you need to make sure before we go into further evaluation. So that is one thing I would like to reiterate and address to the junior doctors mainly, when you get the patient not controlled, please do check it, because even though the first time is correct, after a month they will get it wrong. So always check your inhaler technique. And here, I don't think it's just pure difficult asthma. It is something else other than asthma, as Sir said. So it is highly, probably it is maybe just an asthma mimic here, and we'll have to think about eosinophilic diseases in this patient.
Thank you, madam. So in the follow-up, in April this year, she came to us with a repeat full blood count, and we noted that there was a significant reduction in eosinophilia. Still, the eosinophil count was high at 673, but it had markedly reduced from the values over 8,000 before. However, despite the initial clinical improvement following the IV pulse steroids, the patient still complains of poor symptom control with nocturnal wheezing and cough, despite a satisfactory compliance and inhaler technique, which we assessed here. And the asthma control test was administered on her, which revealed a score of 9, revealing uncontrolled asthma. And we repeated the FeNO, which was found to be elevated at 97 to 99 parts per billion. And she also complained of symptoms suggestive of dysfunctional breathing, such as air hunger, hyperventilation, etc. And we also noted her to have apical breathing pattern during the clinical encounter. However, formal cardiopulmonary exercise testing has not been done until now. And in addition, vocal cord dysfunction was clinically suspected based on symptoms. That is, the VCDQ score was 25, and the spirometry. And formal laryngoscopy is also awaiting. And she's also awaiting a fungal skin prick test for further evaluation. So, the next question.
Yeah, so the ACT score is very low. So is it reflecting a poorly controlled or uncontrolled asthma or something else?
So, as we see, the ACT score alone per se cannot be taken as uncontrolled asthma. There are other key elements like vocal cord dysfunction, dysfunctional breathing, in which we say, as we see your clinical observation in clinic that she had a predominantly apical pattern of breathing using accessory muscles. We tried to get a video, but she was not very happy with that. And then her VCD score is high. So ACT score, though it must be interpreted in clinical context. This patient's FeNO is also still high, but yet we feel that her low ACT score may be contributed by the dysfunctional breathing and the VCD or vocal cord dysfunction, inducible laryngeal obstruction also. Dinesh,
so as said very correctly, even though we use the ACT score to look for asthma control, it is exactly not asthma control. This is a symptom-based score. So it will tell you whether the symptoms are controlled or not. So the symptom control can be, as said, contributed by a lot of other conditions such as dysfunctional breathing and ILO. So it is a symptom control rather than asthma control what we use.
So, unifying diagnosis, what are your thoughts?
I would think that the patient has having EGPA or eosinophilic granulomatosis with polyangiitis in the asthmatic phase, not yet evolved into the vasculitic phase, because the ANCAs can be negative. Only 30 to 70% MPO ANCA will be positive in this patient. I think it's still we will have to monitor the patient closely and follow up and see. I think still she's in the asthmatic phase of EGPA. Two other things I would like to comment on. There was a ANA mentioned in earlier also, in this case also, 1 in 160 in the earlier patient. But the pattern becomes important. The pattern is this DSF70 pattern, where there is dense fine speckle pattern, which you may find in normal populations. So I would think that this patient is still is more likely logically looking at the spirometry, looking at the air trapping and the lung function, looking at the FeNOs, TH2 type eosinophilia and the HRCT findings. I would say that the patient is EGPA in the asthmatic phase yet.
Thank you, sir, madam.
Right. Thank you, Nipuni, for entertaining us with this interesting case. And I think do we have any questions? So we can entertain a few questions from the audience. Right, so in the absence of the questions, I think it's time to sum up the session. And I would like to thank Dr. Amita Fernando sir and Dr. Dilesha for giving us some expert opinion with regards to those two cases. And thank you all for listening. Thanks.
We are truly grateful for your insights, sir and madam. Now I call upon Dr. Sumana Handagala, our president of Sri Lankan College of Pulmonologists, to hand over the token of appreciation to our respected panelists, Dr. Amita Fernando, senior consultant chest physician, and as well and Dr. Dilesha Vadasinghe, consultant chest physician and senior lecturer. And I call upon Dr. Chandana Dahanayaka, the moderator of this session. As we wrap up this year's World Asthma Day, let us carry forward the message that asthma doesn't have to define a person's life. Through awareness, correct medication, and community support, we can ensure that every breath is a comfortable one. Let's make every day a day to breathe easier. Thank you for joining us in this crucial fight. I now invite Dr. Dilesha Vadasinghe, Senior Lecturer and Consultant Chest Physician, Department of Physiology, Faculty of Medicine, University of Kelaniya, before we wind up, to express our gratitude to all who have made this day successful.
Thank you. It is my great privilege and pleasure to propose the vote of thanks at the conclusion of this very successful World Asthma Day Symposium 2026 on the theme Access to Anti-Inflammatory Inhalers to Everyone with Asthma, still an urgent need. On behalf of the organizing committee, I would like to extend our sincere gratitude to the President of the Sri Lanka College of Pulmonologists, Dr. Sumana Handagala, for the guidance and encouragement. And a very special word of appreciation should go to the Chairperson of the Airway Assembly, Dr. Samanmali Dalpatatu, for taking the lead in organizing this very successful symposium. And we are deeply grateful to all our distinguished speakers for their excellent contribution today, with each presentation adding immense value to the program and also our foreign speaker. So I would like to thank Professor Christine Jenkins, whose insights developed on developing national action plans and blueprints for asthma and COPD, which gave us an important international and policy level perspective. I would like to sincerely thank Professor Asita De Silva, the head of the Clinical Trials Unit, Faculty of Medicine, University of Kelaniya, for his kind support in arranging the foreign speaker and helping strengthening the academic value of our program. Our sincere appreciation goes to our sponsors, Cipla Pharmaceuticals, with the team of Mr. Akalanka Panangalage and his team, who has been supporting us generously in making this event a success, and their valuable contribution throughout the academic program for us. I would like to thank the venue organizers of Glenmark Auditorium, our audiovisual team, Mr. Nalina of Impress Events and his team, and also I would like to acknowledge College Administrative Secretary, Mrs. Sonali, and our pre-intern Dr. Nawod for their hard work in coordinating this. My sincere thanks to our compeer, Dr. Nishant Sekar, for comparing today in a very professional manner. And most importantly, I would like to thank all our participants, the on-site and online participants, for joining us today. And your support is what is keeping us going. And to conclude, let's hope that today's lectures and today's insight would help in improving asthma care in Sri Lanka in the near future. Thank you for everybody who was involved in making this event a success. And lunch will be served outside. Thank you very much for coming today.